Welcome, everyone. My name is Dr. Ibiai Dagogo Jack. I'm a thoracic oncologist based at Mass General Hospital, and it is a pleasure to have all of you guys. Thank you for joining us, whatever time zone you're joining from. We have a very, very exciting program with 4 expert speakers, a diverse array of subjects ranging from small cell lung cancer to early stage lung cancer, thinking about combinations. And as lung cancer is really highly evolving as a field, it's incredibly important for us to keep up with the developments, but also for us to communicate it to our patients in a way that we can advocate for our patients, but our patients can also advocate for themselves. And so today's format is, so this is a lung cancer focused OncTalk program. The format is, this is really a live virtual interactive event. We will have 4 separate sessions, each spanning about 20 minutes. After the first 2 sessions, we will have a panel discussion. Then we'll have 2 additional sessions followed by a panel discussion, after which we will have a question and answer session where we really want to take your questions. So we invite you to be, as mentioned, this is interactive. We invite you to submit questions. And then, so we'll just really dive right into the program. And so our first speaker is Dr. Misty Shields. Dr. Shields is a thoracic oncologist, a clinical, basically a clinician scientist or translational scientist who focuses on small cell lung cancer. She has a personal and emotional connection to the disease, and she's a passionate researcher in this space. She's also the founder of the Small Cell Smasher. So an incredible wealth of information with respect to small cell lung cancer. And she's really going to talk to us now about updates with respect to treatment of small cell lung cancer. With that, Dr. Shields, I'll let you start your talk.
Thank you so much, Dr. Dagogo Jack, and thank you to the organizers for the opportunity to be here. Happy Saturday. I am so glad you all are here spending your morning or your day with us. We're so thankful. Now let me just share my screen and we'll get started here. So today we're going to be talking about small cell lung cancer advancements, approvals, and a look ahead. With small cell lung cancer, there's nothing small about it. Small cell lung cancer is an aggressive form of lung cancer, and really not one size fits all. What we know about small cell lung cancer is that it is initially sensitive to chemotherapies and immunotherapies, but it has an innate ability to adapt and lead to relapse and resistance and spread that is ultimately very challenging for our patients and their families. For decades, we know that most patients who are diagnosed with small cell lung cancer would ultimately, unfortunately, succumb to their disease within 12 months of their diagnosis. And so breakthroughs for small cell lung cancer have been desperately needed. So where does small cell come from? What we know from beautiful work that was published a few years ago is that chronic damage to the airways, whether that's firsthand exposure, secondhand exposure to tobacco or cigarette smoke, or other potential toxins in the environment, can lead to damage of the proximal airway or the cancer cells that are in the central airway close to the center of our chest. And that damage over time can lead to the loss of 2 protective genes, RB and p53. From that damage, this leads to reprogramming and deprogramming of these cells that ultimately can evolve and change into small cell lung cancer. What you can see here on the right is the image of a CT scan of a patient diagnosed with small cell lung cancer, where you can see that the cancer begins very close to the airways. And here on the far right, you can see another patient who, as if they're standing here looking at us with their right side and left side as marked on the image, you can see that the cancer really seems to start in the center of the chest and can cause problems very quickly in terms of shortness of breath, having a chronic cough, or coughing up blood. And so what are the genetics of small cell lung cancer? As mentioned, we know that there's 2 very important proteins that are lost in this cancer, and those are RB, or retinoblastoma, and p53, which is a protein that really is called the guardian of the genome. And as you can see here on the bottom right, you can see that when p53 is lost, it's as if it's being tangled up and unable to protect and be the guardian of the genome, allowing for cancer to arise and more damage, including the addition of several different other oncogenes, such as MYC, that may be driving this cancer to grow and spread. What we know for many decades is that small cell lung cancer treatment unfortunately remained the same. There was a desert of advancements. There were many negative trials, and really it seemed like we could not break through this cancer. And so the treatment with platinum etoposide, whether that's cisplatin or carboplatin, in combination with a topoisomerase inhibitor, etoposide, has been the mainstay for almost 40 years. It wasn't until the late 20 teens where we saw the implementation of immunotherapy with atezolizumab and durvalumab that really seemed to help move this field forward and break open the hope that we see today. So this is a slide showing the advancements and approvals that have been for small cell lung cancer in just the past 4 years. I do believe this is the beginning of many exciting advancements that we'll see for small cell lung cancer for extensive stage and limited stage. So let's go through these together. This is a really nice review that was published earlier this year that shows the treatment landscape for patients who may have limited stage or extensive stage. What we know is that the majority of patients who are diagnosed will have extensive stage small cell lung cancer. But as we have seen, about a third of patients have limited stage, and I believe that that number is going to keep improving and going up as we implement and effectively screen patients for lung cancer by CT scans yearly. So what is limited stage small cell lung cancer? So that can be anywhere from stage 1 to stage 3, where extensive stage is considered stage 4. Stage 1 and stage 2 limited stage small cell, if there's no involvement of any lymph nodes, can be potentially resected or removed by surgery. This has historically been a number that's less than 5%, but again, I believe that this will increase over time as we implement lung cancer screening that currently is about 5 to 10% of patients being screened. We would love to see that number be 100%. If we catch it sooner, it's caught in an earlier stage. What we see is that here, if patients have stage 1 or stage 2 and they undergo surgery, that's typically followed by 4 cycles or 4 rounds of chemotherapy with platinum etoposide to help to reduce the risk of this cancer returning and help cure patients. What you can see is if you do have lymph nodes that are positive, whether that's in the side of the chest where the cancer is found or the center of the chest, meaning the mediastinum, then that would be stage 2 or stage 3. If that is confined to one area of the chest, meaning the right side or the left side, and there's no evidence of any cancer outside of the chest by a PET scan and an MRI of the brain, we see that then that is considered limited stage as well, stage 2 or stage 3. And that is recommended to be treated with chemotherapy and radiation therapy. Ideally, this is called concurrent or given at the same time. But for some reasons, patients may receive chemotherapy and radiation separate. Ideally, it's given together. The radiation is given either once or twice daily, Monday through Friday, set at a regimen by a radiation oncologist. And chemotherapy is given for 4 cycles with a combination of platinum and etoposide. The exciting thing that we saw this year was the approval just on December 4th of this year for limited stage small cell lung cancer, seeing the role of durvalumab or immunotherapy. So what is immunotherapy? This is a illustration that I helped publish a few years ago on the left that's showing the role of immunotherapy and radiation. That we can use these antibodies, which are infusions, that can help recognize proteins on the outside of the cancer cells to block those signals and to help promote the immune system to see and fight the cancer. How we really think about it is that we see, the immune system is being trained, as you can see here in the top right, to see good and bad. And these lymphocytes are now armed and ready to see the cancer, fight the cancer, scavenge the cancer, and hopefully provide long-term cure. So what we saw earlier this year at our ASCO annual meeting was the results of the phase 3 randomized double-blind control, randomized to placebo or treatment arm for the Adriatic study. And the results are shown here. What they saw was after patients completed chemo and radiation and were shown to have no evidence of the cancer growing or spreading, they were randomized to immunotherapy monthly for up to 2 years. What we saw from this study was an unprecedented improvement in survival by 22 months, automatically leading to the implementation and uptake of this amongst medical oncologists, and that this is now the new standard of care, as you can see here with the blue line, really improving survival, and this data is still maturing. So this is now considered the new standard of care for patients who are eligible, and talking to your doctor if this is right for you. Patients should receive durvalumab or immunotherapy after the treatment of chemo and radiation for limited stage small cell lung cancer, pending and permitting the cancer scans do not show any evidence of spread or grow after the completion of this regimen. This is a home run and the first huge update in 40 years for limited stage small cell lung cancer. So switching gears for extensive stage small cell lung cancer, this is considered stage 4, where the cancer may have spread to areas outside of the chest, to the other area of the chest, to areas like the brain or bones or liver. And that is something that we do not treat with local therapies like radiation or surgery, but we add on our ways for infusions. So instead of chemotherapy alone, we are now adding immunotherapy, as you saw in 2018 and 2019, with the addition of atezolizumab or durvalumab for these patients. What we saw is that improved overall survival really led to a new standard of care in 2019 and 2020 by the FDA's approval. Typically, chemotherapy for extensive stage with immunotherapy is given concurrently or at the same time for 4 to 6 rounds, depending on the decision between you and the patient, the caregiver, and their doctor. This is typically 3 days in a row, every 21 days. And then after the scans are performed and permitting no spread or growth, then patients are switched to immunotherapy. And this is given continuously as long as it's working and the patient is doing well on therapy. You can see here, these were the 2 pivotal studies with Empower 133 and Caspian, as mentioned in 2018 and 2019 that were reported. You can see here with the blue bars compared to the yellow and red, that there was an improvement and a flattening of the curve, meaning that patients who had a benefit, it seemed like it was durable. And what we know from the 5-year follow-up survival is it improves survival by about 10% for patients who have extensive stage small cell lung cancer, which was the first accomplishment that we had seen for many decades, which was the beginning of many accomplishments we'll see in this disease. For the treatment of small cell lung cancer, if it comes back, which unfortunately, as you can see here, we do see that the majority of patients do have the disease return, which can be quite challenging. And so small cell lung cancer is a very smart, adaptable cancer. And so we have to change therapies if the cancer returns and comes back. What we know is that there have been a breakthrough, as mentioned, in the last 4 years for how do we address this cancer and how can we do this in a smart fashion. So let's go through this data. So in 2020, we saw lurbinectedin get approved and an accelerated approval by the FDA based on a phase 2 study of 105 patients. Lurbinectedin is a unique chemotherapy. It's actually a semi-synthetic chemotherapy. It's an alkylating agent, meaning it binds to DNA and causes damage in the DNA. It's actually derived from the C-squirt, and it's a daughter compound from a drug called trabectedin. It is a drug that's given every 3 weeks as an IV. And what they found in the study is that 35% of patients who received this therapy responded, meaning their tumors shrunk and they had good disease control. What you can see in the top right is that there were some patients who had remarkable benefit, and we really need to know who those patients are so we can select those patients for this therapy. As you can see here, receiving 11, 13 plus months of therapy. I do want to, portray a personal anecdote here of a patient that I saw while I was in my fellowship. And this is a patient who was diagnosed with extensive stage small cell lung cancer. They received 4 cycles of chemoimmunotherapy followed by immunotherapy. And while on immunotherapy maintenance, unfortunately, their cancer did return, as you can see here in the bottom scans, the 3rd panel. And when that happened, the patient was switched to lurbinectedin right after it was FDA approved. And the patient received 24 cycles, where we know that real world data is about 4 cycles. Received 24 cycles, unfortunately had personal reasons that they had to come off of therapy. And now 2 years later they are still alive with no evidence of disease, doing well, off of therapy for extensive stage small cell lung cancer. So durable responders to lurbinectedin do exist. And how do we find them? These needles in a haystack. We just saw the press release of IMforte, which is the role of moving lurbinectedin up into the maintenance setting for immunotherapy. And so how do we use this and sequence the best? And so I think seeing this data, we know that these are going to be released here in 2025, hopefully. And so with that, we want to know how do we use the tools in our toolkit in the best, smartest fashion and the best combination that makes the most sense to give patients and their families the best outcomes possible. So stay tuned on this. Moving forward, we saw a very exciting update with a drug called tarlatamab that was in May 16th of this year, 2024, for the accelerated FDA approval based on a phase 2 study for extensive stage small cell lung cancer. And so what is tarlatamab? So what you can see here is that there are proteins on the outside of small cell lung cancers. You can see here highlighted in yellow, the DLL3 protein. This is on the surface of the small cell. And what tarlatamab does is it bispecific T-cell engager known as a BiTE. And what it does is it interacts with the DLL3 on the small cell, and it interacts with the CD3 on an immune cell, forcing them to engage, forcing them to see each other, and forcing the small cell lung cancer to be approached by the immune cell. How I'd rather you think about it is this is a super glue. This glues together the small cell lung cancer and the immune system to force them to see each other and to force the immune system to recognize it, to engage and kill the small cell lung cancer. The data that led to the FDA approval was the Delphi 301 study. This was a phase 2 study. There was a phase 3, meaning 1,000 patient study that is ongoing. These patients were randomized to one of two treatment arms, whether it was a 10 milligram dose or a 100 milligram dose. And what they saw was that patients who responded about 32 to 40% of the time, when they responded, it was durable. It was really over a year. You can see here in the top right panel that when patients responded, survival was maintained. And you can see that past 12 months, it really seems there's a flattening of the curves, which is what we want to see. The patients are doing well, they're alive and with their families. Now, as part of the approval on May 16th, there was a boxed warning on the package insert of this drug looking at the role of cytokine release syndrome and neurotoxicity. And because of those, the FDA and the company agreed to require at least a 22 to 24-hour observation in a hospital setting for the first 2 doses, cycle 1, day 1, and cycle 1, day 8 of this tarlatamab infusion, as there is step up dosing from 1 milligram to 10 milligrams, which would then be maintained every 2 weeks from there on out. So what is cytokine release syndrome? This could be an array of symptoms that can look as simple as a fever, having flu-like symptoms, having fast heart rate, but it could be as severe as respiratory failure, heart failure, other organ failures where we may need to bring you to the ICU, provide additional support like oxygen, potentially even something like a ventilator to support you with medications like steroids and tocilizumab to help calm and cool down the immune system that is overengaged from that super glue. What we know about tarlatamab is it is effective in patients who have brain metastases. You can see here, this was data that was presented and published earlier this year in our Journal of Clinical Oncology. And what we can see here is that patients had changes in known brain mets with the addition and treatment of tarlatamab. You can see here that depending on the patients who had brain mets and received radiation, that they had deepening or shrinkage of their brain mets with the treatment of tarlatamab. 87% of patients who had pre-existing brain mets had benefit in the brain from tarlatamab. And what we see is that really there's a nice concordance, meaning that what we see in the body is what we see in the brain, what's going on. So this is very hopeful because this can be a sanctuary site for small cell lung cancer. And we want to make sure we address the whole patient and not just one area. We know that there have been very exciting updates with antibody drug conjugates. Dr. Alyssa Cooper will speak to this more. And so just to introduce this in small cell lung cancer, this is like a Trojan horse. You can see here in the bottom panel of the circle that ADCs are antibodies that are hooked to chemotherapy. And the antibody is unassuming. The small cell lung cancer takes it in like a Trojan horse, and the chemotherapy is then released inside the cancer cell like a missile to deliver chemotherapy to the areas that are of need, which is the small cell lung cancer. There are many exciting targets. I'll only speak to one today, but what we can see is that for small cell lung cancer, there's very exciting drugs against TROP2, which is sacituzumab govitecan, B7H3, which I'll speak to, which is the Daiichi compound 7300 or IDXD, as well as SEZ6, which was ABV011 and reformulated to 706. So speaking to IDXD, we say that patients have, this was a study that was presented earlier this year at World Lung, our conference on lung cancer, and that they saw that 2 doses of IDXD, 8 milligrams or 12 milligrams, seem to have similar improvements in helping control the disease and helping to improve overall survival, and that there might be a hint with the 12 milligram dose being more beneficial. We saw that the response rate actually was doubled from 26% to 54% with the increase in the dose. And so the 12 milligram dose is really the dose that will be explored further. What we see is that, again, the intracranial or the brain responses from brain mets with these diseases, with these treatments with IDXD and antibody drug conjugates, we see it working in the brain, that 66% of patients and 50% of patients on the 8 and 12 milligram doses had responses in the brain as well as in the body. And so this is very exciting that this can go into the brain and help fight cancer in the brain. So finally, we have more understanding of small cell lung cancer where we have neuroendocrine subtypes. These are the signatures that the cancer uses. I like to think of it as dials on the radio that are turned up or down that control many thousands of genes in the small cell lung cancer as drivers to say go or no go in this cancer. We know that those subtypes are transcription factors. They're proteins that turn on many thousands of genes. And those are known as NeuroD1, ASCL1, Tau2F3, and an inflamed subtype. There's data to suggest that those potentially themselves cannot be targeted, but potentially they are turning on genes and proteins that can be targeted. And so with that, the Southwestern Oncology Cooperative Group, or SWOG, is looking at a trial called PRISM, which is using precision medicine, using these subtypes to then further refine treatment in that immunotherapy maintenance phase that we talked about, whether that's going on atezolizumab or durvalumab maintenance. Is there a way that we can improve what we are doing based on the subtypes that we see? And so this will enroll about 900 patients, hopefully beginning next year. The principal investigator is Dr. Ann Chang at Yale. And PRISM or S2409 will look at how can we modify and treat patients in a more refined fashion based on these subtypes. So stay tuned. So I hope that today you have seen that there are novel agents that are bringing hope and change for small cell lung cancer. As you can see, tarlatamab, immunotherapy, the role of lurbinectedin, antibody drug conjugates. This is the time of hope and change for small cell lung cancer. In conclusion, I'd like to close with a shout out to our wonderful support group that is focused exclusively on small cell lung cancer, known as the Small Cell Smashers. This was founded by myself earlier this year and in partnership with Longevity Foundation. Give us a follow on Facebook or Twitter. We have a wonderful speaker series to get up-to-date information. We have a lovely community of support of patients and their families, rooting each other on, raising awareness, and we're spreading hope and ending stigma for this disease. So with that, I'll conclude, and thank you for your attention and time.
Dr. Shields, thank you so much. That was a wonderful talk. You really kind of distilled very complex concepts, I think, to in a very relatable fashion. I love kind of the super glue radio dials and other things. And
Absolutely.
so thank you.
Thank you.
Our next speaker is Dr. Alyssa Cooper. Dr. Cooper will be discussing antibody drug conjugates. Dr. Shields gave a little bit of a tease about antibody drug conjugates. So Dr. Cooper is a thoracic oncologist at Memorial Sloan Kettering. I like to think of her kind of as a Renaissance oncologist in a way, in that Alyssa has expertise across various areas. I've heard her give talks on antibody drug conjugates, and I've always come away learning a lot from the talks. And I think she has a way of communicating it quite, I think, in a way that is easier to grasp. And so with that, I'll turn it over to Alyssa.
Thanks very much, Dr. DeGogo Jack. Thank you so much to the organizers for this invitation, for this great Saturday program, and to be in the company with all these great oncologists. Such a pleasure. So I will try to distill this very complicated topic, antibody drug conjugates in lung cancer, into kind of simple terms. So we won't sort of go too deep into any one concept, but I do look forward to your questions later if they come up. So first, during this talk, we're going to review the structure and function of what an antibody drug conjugate is and how they're being applied in different subsets of lung cancer. First, in non-small cell lung cancer, which is the more common type of lung cancer, ADCs, I'm going to use the term ADCs for the antibody drug conjugate throughout the rest of this talk. They're being used in certain subsets of lung cancer for patients with certain genetic markers, and in combination with standard chemo and immunotherapies. Secondly, Dr. Shields just alluded to this, ADCs in small cell lung cancer are making a huge impact over the past couple of years. So we'll review a little bit of that data. And lastly, we'll talk about some future directions. So let's start with what an ADC is. Dr. Shields sort of used this Trojan horse analogy. It's a complex drug molecule composed of three parts. The antibody targets a specific protein called an antigen on the cancer cell. So it's sort of sticking out of the cancer cell, ready to be sort of targeted by this antibody piece here. And it's linked by a linker to what is called the payload, or sometimes called the warhead. You'll see different words used for that, which basically means it's a very potent and toxic chemotherapy molecule. And they found that this drug delivery system can be used to actually to deliver much stronger and more potent chemotherapies than can be used in sort of their naked form without this sort of structure, because it would be too damaging to people's normal cells to just sort of use these very, very strong chemotherapies. But sort of cloaked as they are able to be delivered to people more safely and actually effectively. And the reason for that is that these molecules are not active until they're separated from the linker, and that only happens once they get to the tumor cell. So looking at that a little bit more closely, the way that this is arranged is that the molecule travels to the tumor cell through the bloodstream, where the antibody then attaches to that protein on the outside of the cell, as I said before, and then it's internalized into the cell. So it's sort of like sucked in, you can see, into that little internal vacuole is what it's actually called, but it's just like a little pocket inside the cell. And inside that little pocket there, those chemotherapy molecules, those yellow things, are separated from the molecule. You can see they're broken down here. So the molecules sort of taken apart. And then the toxic molecule here is able to get into the cell and damage it. So it's sort of like, it does its thing where it's really damaging the cell and ultimately can cause it to die. The cool thing about ADCs is that there's this effect called the bystander effect, where these little yellow molecules, these chemotherapy molecules here, can diffuse over to another cell even without the marker on the outside. So you can see that this other neighboring cell doesn't have a marker on it, but still was able to uptake these chemotherapy molecules and can still be killed. And so even if not every tumor cell has the marker on the outside, there still is the potential for killing the neighboring cells. This is just a figure. It's actually even a couple of years old now at this point, but this technology has really exploded over the past decade or so. This chart is showing you from 2011 to 2022, the development of ADCs across oncology. This is not lung cancer specific, but even just showing, you can see in 2021 and 2022, the really, explosion is really the word for it, of how much these agents have grown to show promise in oncology. And this is only increased over 2023 and 2024, which is not shown on this graph. So to start here, we'll kind of take HER2 altered non-small cell lung cancer as sort of the quintessential case of what we've hoped for these drugs. And this is just to set the stage before we look at this, before we look at the data for the drug that's used in this kind of cancer. That HER2 is a gene that can be altered in a few different ways in lung cancer. The gene itself can be amplified, so that means there's multiple copies of the gene. The DNA can have a mistake in it, which we call a mutation. So there's a little change there in what the DNA actually says, and that can cause cancer to grow. And then the HER2 protein actually, so this is the gene and this is the protein. The protein can be what's called overexpressed, and that would be sort of sticking out in the cell membrane here, and there's many copies of the protein. And that can be more common than either of these other two, the gene amplification and gene mutation. So we'll focus on mostly on the gene mutation, which is an important subset of non-small cell lung cancer, looking at this next slide. So an agent called trastuzumab deruxtecan, all of these drugs are kind of like a mouthful term here. Trastuzumab, so the first word tells you the antibody, and the second word tells you, I should have actually thought about this. The first word tells you the antibody, and the second word tells you sort of the chemotherapy warhead piece of it. So trastuzumab targets HER2, and this is just telling you the chemotherapy part of it. So it's an anti-HER2 ADC. In HER2 mutant non-small cell lung cancer, was tested a few years ago in a clinical trial and was shown to be extremely successful. To sort of orient you here, I think Dr. Shields had shown you some of these kinds of plots, and I'm not sure how many of you are familiar with what these look like. This is called a waterfall plot, and each of these bars represents a patient, and this is showing the extent to which their tumor has shrunk in response to the therapy. And so this is the kind of waterfall plot as oncologists that we want to see. Look at this. Most patients really across the board have experienced tumor shrinkage, which is super exciting. But as you can see here, and I kind of have called out on this graph on the bottom, that this was really only super impressive. And so this is the response rate of 55%, but disease control rate of 92%, meaning that 92% of people had stable disease or response to this drug, which is phenomenal, was much higher than what we saw in HER2 overexpression, which, as you recall, was the protein that was sort of sticking out from outside the cell. So these numbers were not as good as what we saw in HER2 mutant lung cancer. So I think that's really interesting and sort of a mini case study that really is indicating that what's most important for this new class of drugs is that every piece of this, the antibody, the linker, and the warhead, and the target really matters. So drilling down on the target is going to be a sort of a common theme moving forward when we look at what else has been in development. So because we found sort of this drug that worked really well for patients with HER2 mutant lung cancer, we thought, okay, let's see if we can try to find something that will work for more general lung cancer in general, and really be an option for more patients who don't have sort of the specific marker. Because as you remember from the gene mutation little graph there, that only occurred in about 4% of patients. So we really want to ultimately try to reach a broader audience. And so this protein called TROP2 was sort of an exciting target because it's overexpressed in a big proportion of non-small cell lung cancer tumors. So almost 2/3 of adenocarcinomas and almost 3/4 of squamous cell carcinomas, which is really exciting. And there had been a precedent for using ADCs targeting TROP2 in other cancers. For example, in metastatic breast cancer, which is what this graph is showing you on the right here, the drug sacituzumab govitecan, which targets TROP2, was compared to physicians' choice of chemotherapy in metastatic breast cancer and performed really well. And it's been like, now it's a really standard treatment for patients with metastatic breast cancer. So we thought, let's try to apply that to lung cancer and see what happens. And there were two very similar agents, sacituzumab govitecan, which I just said on the last slide, and datopotamab deruxtecan, which were compared in very similar trials against this chemotherapy docetaxel, which is our very standard second-line chemotherapy for when patients have had cancer grow after they have their first line of treatment. And unfortunately, the results were not super exciting. They were a little disappointing for in terms of what we had hoped we would see. In the sacituzumab govitecan trial, there was no progression-free or overall survival benefit. Progression-free meaning like patients did not have more time until their cancer progressed, depending on the arm that they were on. And in the datopotamab deruxtecan trial, there was a progression-free survival benefit, meaning patients had more time until their cancer progressed, but it was only a little bit of time and no overall survival benefit. There might be some other things to consider when oncologists are picking a regimen for patients, including like the schedule that the chemo is administered on, if specific side effects may be, intolerable or sort of less, desirable for some kinds of patients. These ADCs did have a higher response rate than docetaxel, which is, something that may actually come into consideration if people have really symptomatic lesions, like in the chest where it's causing trouble breathing or pain related to lesions. So it's, shrinking can sort of be a good marker there. And then of note, the datopotamab deruxtecan drug did perform better in adenocarcinomas, not so well in squamous. So that might be something that we would also sort of take into account. So, but I think we're not quite ready to give up on these drugs because I think that if we could just sort of, as I'm saying, find the right marker, find the right target, maybe we can sort of understand in whom should we apply these novel therapies. And at World Lung this past year, which is a conference where it's just totally focused on lung cancer, there was a presentation where we saw that, this word immunohistochemistry means basically TROP2 on the surface of the cell did not predict who was going to respond to these drugs or not. And that's kind of counterintuitive because if the antibody is targeting it, you would think that that should be linked, but unfortunately it's not. So we have to think a little bit more creatively about how we can understand why and how these drugs might work. And so scientists then have now tried to understand, is there a different way that we can look at TROP2 and better try to predict which patients' tumors might respond or not? And so they've come up with this sort of novel way to measure TROP2 via computational pathology. So it's sort of automated via computer measurement, and it calculates the expression on the outside versus the inside of the cell. And they found that this novel measurement has been more predictive than standard methods that are being used so far. The issue is that so far this is just sort of like within the context of clinical trials. And so I think, the challenge and the opportunity here is to really disseminate this to, the oncology community at large, and how can regular oncologists sort of get their hands on this. Even academic centers may not have access to this kind of technology yet. So I think that's sort of the next big frontier in terms of trying to apply these therapies. Quickly moving to, that was sort of lung cancer without a specific marker, but looking at specific subsets of non-small cell lung cancer, EGFR mutations, I think, as many of you know, is a very common subset of lung cancer that has a genetic marker. And this ADC called patritumab deruxtecan, or HER3-DXd for short, was evaluated in patients who have EGFR mutant non-small cell lung cancer, had already received an EGFR targeting pill and chemotherapy. So their cancer had grown after a couple of lines of therapy. And basically, they picked the dose for this drug and looked to see what the response was. And here's another one of those waterfall plots. And I think, as you can see here, it's pretty fair. It's actually, decent performance here in terms of how well does it perform for these patients. But I think the takeaway message here from this sort of busy bars here under the waterfall is that when patients have cancer grow after EGFR targeting therapy, there are many different reasons or mechanisms of resistance why that might happen. And this drug appeared to be active despite the mechanism of resistance. And I really think that's where its ability to shine lies, and that we might be able to reach for it in sort of a number of subsets of these patients with EGFR mutant lung cancer that has grown after an EGFR targeting pill. Coming up, there is a new trial which is going to look at HER3-DXd versus chemotherapy after EGFR TKI, that's tyrosine kinase inhibitor or the pill. So for patients who have received targeted treatment with a pill, they're going to randomize patients 1-to-1 to this drug HER3-DXd versus chemotherapy. And I think that this trial will be very enlightening to determine, can it outperform chemotherapy in this setting, which I think is a very standard option that we often reach for. So that this will be exciting to sort of understand these results. One other subset of non-small cell lung cancer is MET positive lung cancer. MET is a protein that can be expressed on the surface of the cell. And so scientists thought that this was going to be a good target for an ADC, as we've sort of discussed this whole time, that the antibody can come and target the antigen on the outside of the tumor cell. So because MET is expressed outside the tumor cell, we thought that this would be a good option. This drug, telisotuzumab vedotin, targets MET and was tested in a number of subsets, but it found it was only really efficacious enough in patients who had non-squamous lung cancer and had EGFR wild type, so non-mutated cancer. And so patients received this drug in the later line, so they had already received, chemotherapies or immunotherapies. And the hope was basically that this biomarker, this target, can sort of serve as a proxy for seeing like how well might people respond. The CMET high, so it's patients whose tumors had a really high expression of this protein had a response rate of about 34%, intermediate 22%, and overall just about under 30%. I think that's fine, but I think overall we do sort of hope for more for that for our patients, especially with such a targeted therapy. So remains to be seen what will happen with this drug. I think something to consider and to look out for moving forward are going to be these randomized trials, which are currently enrolling, but we don't have any data are for looking at whether these drugs are going to replace any proportion of the standard of care, or are they going to be used in combination with current standard of care, which is platinum-based chemotherapy and immunotherapy. If we were to combine these drugs, for example, ADC and chemo and immunotherapy, is that efficacy going to be very impressive and enough to make up for any sort of extra side effects or toxicity? I think these questions are going to be super important and remain to be seen. And the results of these trials will be able to tell us, for example, for people who have a PD-L1 score on their tumor, which is, a marker of how well immunotherapy alone might work. If they're randomized to immunotherapy alone versus this is datopotamab deruxtecan plus immunotherapy, that will sort of give us the data. How extra effective is it? How extra toxic is it? And so we really need to see these data to sort of understand how these drugs are going to fit in the future, and whether there might be special populations of patients who might stand to benefit most. For example, maybe patients with brain metastases might need this escalated therapy, or other sort of vulnerable subsets. This is just a quick slide to show you that while ADCs themselves are a new drug, there are many sort of even further novel developments moving forward with, all parts of the engineering of the ADC sort of under development, novel linkers, novel targets, novel payloads. And so all of that is coming and mostly in preclinical development now, but will be coming to clinical trials soon in the coming years. Really quickly to apply to small cell lung cancer, Dr. Shields gave you basically the rundown of this trial, ifinatamab deruxtecan, IDXD, a B7H3 targeting ADC. This graph over here is just showing you that B7H3 is more highly expressed in cancer cells than in normal cells. This is comparing cancer cells versus normal control cells. And as Dr. Shields showed you, I think the IDXD dose of 12 milligrams per kilogram showed a very impressive waterfall and response rate for patients with small cell lung cancer treated in the later lines, which is a challenging proportion of patients to treat usually. our old TROP2 targeting ADC, sacituzumab govitecan, as you recall, was a little bit underwhelming in non-small cell lung cancer, but in small cell lung cancer, treated in patients who have, who were pre-treated, had sort of had disease progression after first line therapy, a response rate of 42% with this waterfall. I think very exciting for these patients who generally have not had a lot of exciting options in these settings. Also quickly, this SEZ6 targeting ADC, ABD706, as you can see, this SEZ6 is a protein that's more highly expressed here in small cell lung cancer and neuroendocrine cancers. And here's sort of the rest of the expression across the board of other kinds of cancers. This was very exciting. A small proportion of patients, only 20 or so patients, but still a very high response rate of over 60%. And this waterfall, look at this really impressive tumor shrinkage in a couple of patients who were really heavily pretreated, a lot of them had over 3 lines of prior treatment. So super exciting and promising in the time to come. So to sum up, ADCs are an exciting new class of drug, though for non-small cell lung cancer, I think we hope to see a bit more clinical efficacy for our patients. But in small cell lung cancer, this has been a really exciting area of investigation and really promising, shown to be really effective even in the later lines. These are novel drugs with new side effects, and basically physicians, nurses, clinics, patients are all going to need to be educated on the unique side effect profiles, which require attention and education to manage new symptoms. But really be on the lookout for these novel combinations with chemo and immunotherapy and other agents, because they're coming. And I think at the end of 2024 here, the future of lung cancer treatment is bright. Thanks very much.
Thanks, Alyssa. Thanks, Dr. Cooper. So I think you and Dr. Shields both ended with kind of that promising outlook for the future. And I think that's something that we should all kind of grasp and hold on to. So again, thank you for that talk. It really was a lot in terms of kind of decoding the alphabet soup of ADCs, and also kind of putting into context both in non-small cell and small cell. So kind of wedding the two talks. And so for the next 12 minutes or so, we're going to answer a couple of questions. So Dr. Cooper and Dr. Shields will answer a few questions pertaining to the topics. And so in thinking about both of your talks, I guess the first question is for Dr. Shields. So it gets to the thought about kind of how complicated our treatments are becoming, and how do we explain it to patients and also to other people who are members of the team. So tarlatamab is a therapy that it's given inpatient, at least for part of it, and is also kind of complicated. So I liked the glue that you had mentioned. How do you explain some of the side effects to patients in terms of what they might experience, and also how to monitor for them when they go home? Because some of these things don't happen while you're in the hospital.
Yeah, no, thank you, Dr. Jack. This is a very important message to patients and their families. I think, definitely in our small cell smashers community, we are frequently seeing questions about tarlatamab, and rightfully so. It's a new drug. These BiTE therapies are new to small cell lung cancer. They're not new to the oncology community. We've seen them in a lot of heme or malignant heme, a lot of blood cancers, like lymphomas and the sort, and leukemias. But now it's really moving towards advanced solid malignancies like small cell. And so this is a new shift for our patients, and honestly for a lot of thoracic oncologists like ourselves. And so, explaining to patients that this is to be given, for the first 2 treatments in the hospital, to be able to have that potential opportunity to help support patients if something was to go awry early, just for the safety of the patient. It may be completely unnecessary. What we know is that about 55% of patients will have cytokine release, but to what degree? And so we know based on the study that most patients experience mild symptoms. What that looks like is maybe just a fever and a fast heart rate. We give fluids, we give Tylenol, patients feel better, and they get to go home. But there are small subsets of patients that this could be really severe and really scary. And so we need to be able to act on those quickly. We don't want them to be home if something happens. And so, my institution actually holds up to 48 hours just to be safe. I have had patients that have experienced cytokine release at 30 hours, 36 hours, 40 plus hours. And so it's important to stay within an hour of your hospital system, ideally, so that if there was something scary to happen and you're at home, you call the on-call doctor, you call the direct number to your clinic, you make sure you get a hold of someone in the clinic to let them know you're coming in and go to the ER so that that can be managed quickly and appropriately, because sometimes this can escalate from 0 to 60 without warning. Most patients, I will express again, most patients have mild symptoms, but it's just those rare situations that we want to support patients. And so, it may seem like overkill, and hopefully it is, but we just don't want to have any patients fall through the cracks. And so we really want to help support everybody in doing so. And I know that there was actually a study just at ESMO IO this week with Dr. Ann Chang presented a poster about the 6 to 8 hour observational study with the expansion cohort of tarlatamab. And if patients were able to stay close to the cancer center or the infusions center, that those patients actually didn't see a huge increase in safety signals as long as they were observed outpatient. And so I think more to come about who are these patients, what are the biomarkers that we have to say these are the patients who are going to have these happen, and that we can help let everybody else maintain a normal schedule and going home after an infusion instead of a hospitalization. But we're just not quite there yet. So we want to be safe and not sorry.
No, I completely agree. It doesn't always obey that like 24 to 28 hours, I guess, monitoring schedule. So I often do extended missions. And we have to think about our hospital system and also where the anxiety is related to being hospitalized, all sorts of things. So trying to do it safely, but also in a way that kind of respects people. And so the next question is a bit of a hard pivot. This is for Dr. Cooper. And so we've spent a lot, I think, at these GRACE forums, at various forums in the lung cancer community talking about biomarker testing. I loved how much attention you gave to identifying these ADC targets, but I think it's important for us to kind of contextualize. So does our traditional biomarker testing, here I'm talking about next generation sequencing of tissue or liquid biopsies, so plasma, does it give us insights into how these ADCs might work? And is it for a subset? Is it for everyone where this might be informative?
Yeah, thanks for the question. It's such an interesting and really evolving space, actually. So, of note, only in the past couple of weeks has there been a change in sort of the indication for even those more general ADCs. For example, datopotamab deruxtecan was originally intended to be a drug for sort of all non-small cell lung cancer patients treated in the later line. But actually, the company just withdrew that application within the last couple of weeks, and instead is pivoting and focusing on applying that agent just to patients with EGFR mutations. And so, it's a challenging question without a clear answer, because I think honestly, the development is still sort of ongoing, and the science is still sort of being performed as a sort of like, to help us sort of understand where we are. I think there is some rationale to try to apply some of these ADCs to some sort of genomic subsets, like traditionally, like we think of that are found on NGS. So like EGFR mutations, HER2 mutations, as I talked about with trastuzumab deruxtecan. But, in terms of the other agents, TROP2 is not something that's found on a genetic test, and indeed is actually not even predictive of response. So I think we're in a little bit of a C here, because as I tried to convey, trastuzumab deruxtecan was super exciting and sort of made us think that we were going to be on the right track with like HER2 mutation, HER2 targeting drug. That worked really well. Like that's a partnership that's going to move forward, and we can be able to capitalize on that and sort of recapitulate that for multiple targetable alterations in drugs. And we just have not totally been able to get there yet. So it's a long-winded answer to say we're not quite sure actually how it's all going to pan out overall.
Don't ever apologize for a long-winded answer. We gave you guys massive topics to discuss in 20 minutes each. And so there was a lot of, I think, foreshadowing kind of future talks and future development in this area. And so this is a space that I think applies both to ADCs and small cell lung cancer and can be devastating for our patients. And this is brain metastases. So for Alyssa, the question for you pertains to what do we know about the brain penetration of ADCs? They seem like very chunky molecules. And at the same time, for Misty, the question is, I didn't hear you mention radiation in your talk. It used to be that I could never hear a small cell lung cancer talk without someone talking about brain radiation. And so I want to know with the development of kind of incorporation of immunotherapy in limited stage small cell lung cancer, where does brain radiation stand? And so whichever one of you wants, I mean, let me just pick someone for the sake of like conciseness. Alyssa, we'll let you
Okay,
go
thanks,
first.
Sophia. Yeah, so thanks. That's actually a big oversight that I didn't present that specifically in this talk, but again, the 20-minute time frame. So we scientifically had anticipated that maybe these molecules were very big and couldn't cross the blood-brain barrier. But we've actually been surprised in preliminary data that's come out both in trastuzumab deruxtecan trials and datopotamab deruxtecan trials, where patients with brain metastases actually have had what we call intracranial response. So they have measured brain mets that have not been previously treated, and even brain mets that have been treated but have not grown more, sort of in response to the therapy. And so we've seen that in small numbers of patients, preliminary data. There have not been big publications, but I think we are now a little bit more, we don't feel as nervous about sort of relying on these agents. Just to sort of piggyback off of Dr. Shields' really quickly, there in IDXD and small cell lung cancer, there's also been good intracranial efficacy shown as well. So this is something that is a surprising but good development, I think, for our patients.
Awesome. Yeah, I think drug development always you have to think about the CNS at the same time as you think about the extra CNS space. So for Dr. Shields' answer.
Yeah, so absolutely. This is so the question is really, what is the role of radiation to the brain in small cell lung cancer in this day and age, in this era? Is there still a place? Is it still needed? And so I think that there is a place. My personal preference, my personal practice is to avoid radiation if at all possible. We have such delicate, intricate, novel agents that radiation is not whole brain radiation, particularly, which is called PCI or prophylactic cranial radiation, is not without early and long-term side effects, and that could look like tremendous fatigue, early memory loss, mood changes, weird neurologic symptoms, and so that it's not without potential toxicities. And so that is really a patient and medical oncologist and radiation oncologist discussion. What we know from the Adriatic study is that there were patients that was permitted to have PCI or brain radiation, and those patients did benefit regardless if they had PCI or not with the role of immunotherapy. So I think more to come. I know that when the original studies from Ben Slotman in the early 2000s were done with whole brain radiation for limited stage to help prevent brain metastases, there were a lot of caveats to the study. They were done in the era of CTs and not MRIs. MRIs are much more specific and sensitive to the brain. And not all patients on the study were given a scan. They were only given scans if they were symptomatic. And so for those, I do reserve pause. I think every patient should talk to a radiation oncologist and see what that entails and if that's right for them. But I think my hope is that we're phasing this out and that we only need to use radiation and targeted therapies like stereotactic radiosurgery or SRS or gamma knife, and these really targeted therapies, so we hit the cancer in very minimal areas of the brain and help patients have good quality of life, good function, and have time with their family and friends.
Yeah, so as we get more precise with our systemic therapies, could we become more precise with our local therapies as well? So excellent. So thank you both. So lots of questions, not a lot of time. And so, well, thank you both for joining, and we'll see you later at the question and answer segment. So we encourage the audience, please submit your questions for us. So we're going to pivot to the second half of our program. And for this, I'm going to invite we'll hear from Doctors Julia Roto and Dr. Angel Chen. The first talk is actually by Dr. Roto. She'll be discussing combination therapies for EGFR positive lung cancer. So Dr. Roto is a thoracic oncologist here in Boston. I send her a lot of questions about EGFR mutant lung cancer. She's at Dana-Farber. She's also the clinical director there, has extensive expertise in EGFR mutant lung cancer, and she's going to help us understand what is an evolving and increasingly complex topic in a space where we used to rely solely on a single drug or a monotherapy concept. And so with that, I'll turn it over to Julia.
Hi, everyone, and thanks, Sibi, for the invitation to speak here today. Really, really great to be talking about one of my favorite subjects, which is where do things stand with management of EGFR mutant lung cancer. So welcome everyone who's joined us here today. I'll be covering broadly the topic of EGFR combination therapy, something that's gotten more complicated in the last year and a half compared to what we used to know about this subject. Let's see, there we go, so my disclosures. So my mini agenda for this talk is to cover, what is EGFR mutated lung cancer? I know that some folks here attending this session may have been living with EGFR mutated lung cancer for many years, but there are those who are newly diagnosed. So we'll start out with just some level setting, getting everyone on the same page. And we'll talk about really focusing in on what are the current treatment options for the newly diagnosed lung cancer with an EGFR mutation. How are we thinking about these options? And then we're going to talk a little bit about how does first line of therapy impact choices in the second line and later setting, especially relevant, I know, to everyone who maybe has already had themselves or a loved one has started treatment. So just quickly here, I'm going to try to get my screen working here. There we go. The question is, what is EGFR lung cancer and who tends to get lung cancer with an activating EGFR mutation? And these are the most common actionable mutation that we currently find in lung adenocarcinoma. It's about 15% in a North American population, but say in Asia, Southeast Asia, you can see rates up to 50% or higher of EGFR mutations if you're diagnosed with a lung adenocarcinoma. So it does vary quite a bit with geographic area. On average, people with EGFR lung cancer compared to our broader population of people who have a lung cancer diagnosis, they tend to be younger at diagnosis, are a little more likely to be women, are more likely to have Asian ancestry, and are less likely to have a history of heavy tobacco use. But I do want to highlight that EGFR mutated disease can affect anyone regardless of demographics. So this can absolutely strike men, people without any Asian ancestry, older individuals, people with history of smoking can all get lung cancer with an EGFR mutation as well. And that's why it's really important to be doing comprehensive testing or having comprehensive testing, regardless of what your personal background or history are, because we don't want to miss anyone who has one of these actionable mutations, EGFR included, because they can add to the list of treatment options and add some very effective treatment options that we don't want people to miss out on. And I will highlight that almost all EGFR mutations are cancer cell only mutations. So they're not in the rest of the healthy cells in your body. They're not something that's traveling through families. There are a few very rare exceptions, and certainly your oncologist can help sort that out if it looks like you have one of the mutations that sometimes has been reported in families or depending on family history. But usually these, and the vast majority, these are not something that's traveling in the family. Let's see, what is EGFR? EGFR is a gene which makes the EGFR protein, which sits on the cell surface, and it turns on and off during normal function, particularly within, we call it the epidermal growth factor. So the epidermis, which is like your skin surface, basically, or anything in your body that interacts with the outside world. So that's skin and intestines, technically. It should turn on and off as needed, but when EGFR is mutated in lung cancer cells, it stays on too much. When it's on, it sends a grow and survive signal, which causes the cells to be more likely to be cancer cells. And our EGFR targeted therapies, the traditional kind of pill-based therapies that we use that I've listed out below there, they really bind specifically to that mutated form, the abnormal form of EGFR, to help shut it down and stop the excess signaling, while trying to spare binding to the normal EGFR that's in all the rest of your cells in order to try to minimize the risk of side effects. And many of the side effects we'll talk about for EGFR inhibitors are because of the EGFR pills, what they do kind of hitting the normal EGFR as well a little bit, despite best efforts to kind of be selective away from it. We've had many generations over the years, and in fact, 2024, this year is the 20-year anniversary of the original discovery and reports of EGFR mutations as being sort of this actionable biomarker in lung cancer. So we now have 3 different generations of EGFR drugs. We have the first generation inhibitors, things like erlotinib and gefitinib. We had second generation inhibitors, that was afatinib and dacomitinib. And we had third generation inhibitors, which is our current generation of inhibitors, like osimertinib and lazertinib. And those are the drugs that, except with rare exceptions, you're most likely to be receiving if you're being newly diagnosed with EGFR lung cancer in the United States today. And these are all pill-based therapies that bind, just as in the figure shows, to that mutated form of EGFR. Now, there are many different types of EGFR mutations, and they all share the common feature of causing overactivation of EGFR, but they differ in how sensitive they are to our traditional EGFR targeted therapies, particularly our EGFR targeted pills, because they all affect sort of the shape of that kind of lock, so to speak, a little differently. So some of them need a different key, i.e. a different inhibitor, to inhibit them most effectively. So this talk is really going to focus on the most common EGFR mutations. These are L858R and exon 19 deletions. And I marked them off on that pie chart there. They make up at least kind of 80 to 85% of the mutations that we find in EGFR when we test, which are actionable. But I will touch just briefly at the end on the other mutations as well, which are that rest of that pie chart there. You can see there's a lot of different other ones that make up the rest of the ones we find. EGFR L858R is one step mutation. It's one of the most common ones. And then exon 19 deletions are actually a collection of many different sorts of mutations that all delete a little segment of this portion of the EGFR protein called exon 19, leading to overactivation. But they do it in just slightly different sizes of the deletions or locations of deletions. So today, and this is something that's really been changing over the years, we have many different classes of therapy available for EGFR mutant disease. You have the original EGFR targeted therapies, and that's right now osimertinib, which I mentioned before is a third generation EGFR inhibitor pill. But there are other classes of therapy we use either upfront or along the way for our patients with this diagnosis. And that may include chemotherapy, and usually does include chemotherapy at some point. Classically, the combination is this carboplatin plus pemetrexed. You may have heard those names before. We also have EGFR MET bispecific antibodies. So that's amivantamab now available, which is active for this particular diagnosis. And maybe in the future, as you heard in our last talk as well, antibody drug conjugates have shown some activity. They're not currently approved for EGFR lung cancer, so we don't have anything we can write just now about a clinical trial, but it's certainly an area that I think is interesting as an example of emerging therapeutic classes. So how do we use these? And I usually tell patients that I expect we're going to use all of these in some format at some point. And in some ways, the question is, how do we combine them and sequence them to gain the greatest effect against the cancer, while ideally retaining the best quality of life possible, trying to minimize the amount of time people spend with toxicities of therapy. And of course, that may be different for one person or the other, depending on health or preferences around care. So where are we now with treating newly diagnosed lung cancer with a classical EGFR mutation as of 2024? We really have three big options that are all available, that all have good data. I'm actually going to run through all three of these to kind of get into some of the nitty-gritty of what do we know about these different treatment options. Option one is osimertinib monotherapy. That's a pill-based regimen. It's one pill a day. So it has the advantage of being an oral regimen. So no IV infusions required, and generally fewer side effects than the combination-based regimens I'll talk about. Fewer therapies, fewer side effects of therapies. But as we look at the data, it does have now a shorter average duration of benefit compared to going with a more intensive upfront combination. What are our upfront combinations? Option two, I would describe as being osimertinib combined with chemotherapy. And that's that combination of carboplatin pemetrexed chemotherapy I mentioned about 2 slides back, I think. And this has the advantage, it's more intensive upfront therapy. You're adding chemo right from the beginning, right at newly diagnosed. And this does come with a longer average duration of benefit before having to switch to, say, your next type of treatment. But it does come with more side effects, especially early on with the chemo regimens a little stronger, a little more intensive. And it does add IV infusions every 3 weeks or so. So, you're taking on sort of the chemotherapy infusion experience and the quality of life impacts by doing this. Option three is actually our most recently improved option. And this is that combination of amivantamab, which is that EGFR MET bispecific antibody, combined with another EGFR pill, lazertinib instead of osimertinib. And this similarly has shown a longer on average benefit compared to osimertinib alone, but it does add IV infusions as well every 2 weeks. And it probably has, I think, the most side effects kind of in an ongoing fashion during therapy. And that sort of limited some of our excitement about using this upfront in the first line setting. We will run through the data. So what do we know about how these things work and what it's like to take them? What are the side effects? These all come from big randomized phase 3 trials where the existing prior standard of care was compared to the new option, whatever that might be. So osimertinib alone, monotherapy, was developed and understood based on the FLORA clinical trial, which is a big randomized trial that compared osimertinib, the third generation drug, to getting one of the older EGFR inhibitors. And this was the original old standard of care back, say, in 2015, 2016, 2017, before we had this data. And they were looking at, is it best to get osimertinib first, or best to get one of the first generation drugs first, and then switch to osimertinib later if you had certain types of acquired resistance that suggested continued sensitivity. So they did this big randomized study in people with a classical EGFR mutation with newly diagnosed. And this is what they saw. They showed that you can improve what's called progression-free survival, which is the time on average before someone's disease begins to get resistant and grow on treatment. You can make that better with osimertinib compared to one of the older EGFR drugs by about 8.5 months, 18.9 versus 10.2 months. And this also led to better control of brain metastases because some of our newer drugs, including osimertinib, have more crossing of the blood-brain barrier and therefore are better at preventing disease resistance or progression in the brain, which is quite important. And it did seem, I think, in practice, reduces risk of some of the side effects we saw on some of the older drugs. It's a little more selective against normal EGFR, so you get less rash or other skin-related side effects. Now, just to quickly step back, in case you don't spend a lot of time looking at these what are called survival curves. I'm going to show a lot of them, and they come up a lot when we're talking about how do you compare therapies. So how do you read a survival curve? Here's an example, progression-free survival. The vertical axis is people living without cancer progression on their current treatment. So sort of the treatment's working. And the bottom axis there is just time, in this case, time in months. And if everyone's having really fast cancer progression, you're going to see the curve drop down really quickly. We have this in the red line here. On the other hand, in a perfect scenario, if a drug worked perfectly, no one would progress. You have a completely flat green, top line there at the top where no one ever has their cancer develop resistance. And in real life, the curves usually look somewhere like the yellow line. We're trying to shift that yellow line to look more like the green line. So just showing the Flora data again, you can see the red line was the standard TKIs there, and the blue line moving up was using osimertinib. We also show that this improved what's called overall survival. So this is not how long does someone live before their tumor starts to grow and we have to think about changing treatment, but how long does someone live overall, which is, I think, in some ways, something we're really looking is to extend duration of survival of cancer as long as possible for people. And here we can see that this improved overall survival. I mentioned better CNS control. So this is an example we call waterfall plots, where you can see that by switching to a newer drug, you get better brain response rates. And you can see those bars all drop further. That's the % decrease in brain metastasis size, and you see better response in the brain. So side effects, that's an important consideration for any therapy. EGFR inhibitors have a few very classic side effects. We think about skin side effects like skin rash or dry skin or paronychia. It's like almost like ingrown fingernails. And we think about GI side effects like diarrhea that we often manage with an antidiarrheal. And there are a few uncommon but serious side effects that come up with EGFR drugs like lung inflammation called pneumonitis or heart side effects like heart toxicity affecting heart pumping function or heart electrical function. So these are things we're watching for when we're treating people with these sorts of drugs. All right, what about combination therapies? So the second option I mentioned was osimertinib combined with platinum doublet chemotherapy. It's 2 chemotherapy drugs together. It's our standard chemo regimen we tend to use for this type of lung cancer. So the FLAURA2 trial was the big randomized trial that now compared this big combination to osimertinib alone as the comparison arm and looked for outcomes, how people did. And again, that primary endpoint, the key thing they were looking at was progression-free survival. And here again, you can see here's the progression-free survival curve on the left, again, showing that now osimertinib, there's the blue line, the chemotherapy combination is the yellow line. And you can see again, improvement in progression-free survival from about 16 to 25 months if you add chemotherapy up front. So we're shifting that curve up a little flatter again. A lot of times we think of actual sort of long-term overall survival as our gold standard for these sorts of upfront combinations where you're taking on more toxicity. Right now, we haven't seen a significant difference in that yet, but the data is immature. So we're waiting to see long-term how people do if they get this sort of combination up front. Side effects are, as an oncologist, what we expect, where we see the side effects of osimertinib, so the EGFR side effects, and we see the side effects of chemotherapy. And chemotherapy side effects are most commonly things like tiredness, low blood counts, nausea are kind of the big ones we're thinking about. And again, this regimen's a little more intensive where there's an extra chemo drug in the first 4 rounds of treatment. That's those blue bars. You can see all those side effects are higher than later on once you're no longer getting the extra kind of stronger drug and just in maintenance. And that I think matches our clinical experience as well. The first 3 months are a little harder. And as you go forward, people are feeling a little better on therapy. Now, I think the big question is who really needs combination therapy and who could start with EGFR inhibitor alone. I think, we're not all, it's not all one diagnosis. People are being diagnosed with very many different stages of disease and different sort of aggressiveness of disease. And these are called subgroup analysis. But I looked at a couple different features of the tumor and said, how do people do with and without these features? So with or without brain metastasis, with and without detectable EGFR mutation in the blood, with different types of subgroups of EGFR mutations. And I highlighted in green the 2 that kind of weigh on me the most. And you can see that in the top left, if you have a brain metastasis, your benefit to adding combination therapy is higher. It's almost more than a year benefit. And that probably speaks to more aggressive disease, harder to treat disease. The combination might be more important. And then in the middle bottom, I highlighted if your EGFR mutation is not detectable on a blood test, it probably means you have slightly less aggressive disease or less extensive disease at diagnosis. And then people did really well with the pill alone, only a 3-month degree of benefit. You can see not a big difference in those curves. And people really had a very good progression-free survival with just monotherapy with osimertinib alone, so option 1. But you can see each subgroup is different. That's something we think about with any individual when we're talking through what makes sense for one person versus another. All right, I just have a few minutes left. I'm going to talk about amivantamab plus lazertinib versus osimertinib. This is that 3rd option I mentioned. It's the Mariposa clinical trial. And I'm going to focus in on the blue box and the gray box. That's the combination versus osimertinib again is the control, so to speak, the standard arm alone here in this study. Otherwise, very similar to the last trial that I showed you. And then just amivantamab's a little different from the stuff we've talked about so far. This little picture on the right shows, in some sense, the structure. It's an antibody which binds to EGFR and to MET, which is a different sort of cell surface marker that sits on the surface of many cancer cells. So it binds to both of them at the same time. And we know that MET is also important, likely in cancer signaling and in EGFR inhibitor resistance. Here's the outcomes from Mariposa. Again, better progression-free survival from 16 to just shy of 24 months with combination therapy compared to the pill therapy alone, so the blue line versus the gray line. And again, currently no significant difference in overall survival, though just like on the last graph I showed you, it's kind of trending that direction. People on average seem to be doing a little bit better with the combination versus the pill alone. Again, going along with the idea that upfront intensive combination therapy with these sort of regimens may gain a little bit of benefit in terms of long-term survival. I think we won't be surprised if it does, but at the cost of some of the side effects that I've been talking about when you start those sort of more intensive therapies up front. I think the Mariposa side effects are one of the reasons why I think a lot of us aren't reaching for this first just yet. It's an EGFR MET antibody. So you see both the classic EGFR side effects like skin rash or the ingrown fingernails. You see some MET-related side effects, which we haven't talked about, but a classic one, if you would target MET in cancer cells, is what's called edema, like swelling in the ankles or kind of lower legs. So something you watch for on this drug. And there's a couple kind of special side effects that go along with this particular drug, including risk of what are called infusion reactions on the first couple doses. And these are a lot like, almost feel like an allergic reaction. So it's something that your doctors need to be aware of and ready to manage, and that you should be aware of if you're getting it, so you know that what's happening is actually something we kind of expect. It happens in about 2/3 of people, but just needs to be treated. And people who get this combination have an increased risk of blood clots. So there are some preventative blood thinners that people should take in their initial months of treatment to reduce risk. It's a little more complicated, I think, and I think some of those skin side effects are a little more significant than some of the other combinations that we've seen thus far. So for me, I don't usually recommend this first, but it's certainly something I'd bring up with patients. Here you can look at the same sort of high risk, low risk subgroups, and same thing as before for some of these high risk situations like having brain metastases or detectable EGFR in the blood. Certainly there's a little greater benefit to getting combination therapy potentially. So one slide on the uncommon EGFR mutations. What about these? So these are the exon 20 insertions. And this is the next most common subgroup, about 10% or so of the ones we find. And there, we've got exon 19 deletions. They pull things into active formation. Exon 20 insertions, you could think of them as pushing things into active formation, is how I think about it, based on each side of the active part of the protein. And amivantamab, the drug I just talked about, combined with chemotherapy, is actually our go-to standard there. And I'm happy to talk about that more in the Q&A. But there are a lot of clinical trials ongoing trying to develop EGFR exon 20 active pills, because our current pill-based EGFR drugs just don't work well against this particular class of mutations. And those have shown some really promising data. So I think we're going to have these sort of agents available in the future. And then we have all the rest. We often call these the atypical EGFR mutations or the uncommon EGFR mutations. These are all really different, and they vary in their sensitivity to our current EGFR pills. For the most common of the uncommon mutations, afatinib actually is approved. It's a second-generation EGFR pill that tends to bind to them a little better. But for some of them, off-label osimertinib might be used if we have some data that there's activity. Off-label amivantamab plus lazertinib, the combination I just talked about for common mutations, has also shown activity for a number of these. And there are also a lot of drugs in clinical trials trying to look at, can we design EGFR inhibitors that are better for these uncommon mutations by deliberately designing for them? And that also is something I'm always looking for patients. So how do you decide? You're really weighing side effects and quality of life versus maybe upfront efficacy and whether someone maybe has high-risk features and needs or wants a more intensive frontline regimen. So I really talk about all three options for an individual patient, and we try to get a sense at what's their individual risk profile and what's their preference around intensity of therapy and quality of life, because it's a very personal decision as well when weighing these two very different experience options. And then I'm running low on time, so I'm going to take one more minute and finish. I'll just point out that when these first-line regimens, if they stop working, we like to reprofile cancer, looking for, is there something we can find to explain cancer resistance to treatment and be actionable with another targeted treatment? And the majority of time, we don't find anything, but occasionally we do, about maybe a little under a quarter of the time. And I marked that out there on that pie chart, some of the things we find that might lend themselves to clinical trials or other acquired combination therapies that might use off-label. But for the rest of that pie chart, the kind of unknown, not readily actionable, there are all-comer strategies either available or in development where the idea is it doesn't matter what your genomic resistance profile is, you still want to have something to use. And our kind of current standard of care go-to, I would say, is chemotherapy combined with amivantamab if you were getting osimertinib alone to start with, or chemotherapy with or without osimertinib, or again, looking for a clinical trial. I'll just do one slide on the amivantamab plus chemotherapy in the second line setting. So this is if you were on osimertinib first and you progressed, what would you receive? This is probably the most likely thing that you would be given. It's sort of the blue line, the blue bar on that chart there. And this study showed that, again, adding amivantamab in at this point, if you haven't already received it, is going to be better than getting chemotherapy alone, about a double response rate. And again, a better progression-free survival, pushing that curve up a little flatter than if you got chemo alone. So how do you sequence therapy? This is how I think about it, because of course we're using each line, then we're switching to something else. And I think if we have the osimertinib alone, you'll probably get amivantamab combined with chemotherapy. If you got osimertinib plus chemotherapy, I think that's more complicated right now. There are other chemotherapy drugs we can try. There's the antibody drug conjugates that have been in clinical trials that I hope are going to become available. And there's things like off-label retreatment with things like amivantamab plus lazertinib. So I think for each person, the line of therapy that we move through is going to change, especially I think as we have initial emerging therapies hopefully coming out of clinical trials. My takeaway points, upfront combination therapies improve progression-free survival and might improve overall survival for the newly diagnosed lung cancer with EGFR mutations, but the benefit is probably greatest if you have high-risk disease features, and the combination is going to add side effects and intravenous infusions relative to simply taking a pill every day. So I think it's a very personalized decision which strategy to follow in conversation with an individual patient. With that, I'll turn us back over to our next speaker.
Thanks, Julia. That was a very, very thoughtful and comprehensive discussion of kind of the things that go into play when you're deciding between combinations versus monotherapy. And so our final talk before we get into kind of the panel discussion and question and answer is on targeted therapies in non-metastatic lung cancer. And the speaker is Dr. Angel Chin. Dr. Chin is an expert in targeted therapies across the board, does a lot of wonderful research in ALK-positive lung cancer. And as we're starting to move these targeted therapies in the earlier stage setting, it's a very fitting talk now to discuss what is the activity in this space, what can we look forward to in the future, and should we be thinking differently about biomarker testing. And so with that, I will turn it over to Dr. Chin.
Thank you so much, Dr. Jack. My name is Angel Chin. I'm a associate professor in thoracic medical oncologist, University of Michigan, and it is my incredible pleasure to speak with you today about targeted therapies in non-metastatic lung cancer. So here are my disclosures. So as we've been hearing quite a bit about in some of our earlier presentations today, we know that non-small cell lung cancer is really divided into these different molecular subtypes. And here we have a lovely pie chart, and probably most updated pie chart about the different mutations that we're really looking into developing therapies for. We're also understanding that if your cancer has one of these mutations, they may have a different response to different treatments, as well as a different a clinical course. When we talk about molecular testing, what do we really mean? So let's just take a step back, because I think we hear a lot about molecular testing, but sometimes it can be really confusing. So you can hear it being referred to as genetic testing or next generation sequencing, molecular testing, mutation testing. We all use these terms almost interchangeably to kind of refer to the same process. What I like to emphasize is the molecular testing that we're really focused on here is not really genetic in the sense that it is passed on from a parent to a child. So these are not necessarily inheritable mutations, but what we're really looking for are actually specific DNA changes that are occurring in the cancer cells themselves. And so when we undergo this sequencing, what occurs is that often these biopsy samples or a surgical specimen is sent to a specialized lab. And then from there, they can extract DNA from the tumor cells themselves, and they look at the sequence, and they're looking at the molecular changes that are occurring in the sequencing of specific genes. And that is how we arrive at whether or not lung cancer belongs to one of these molecular subtypes. But what I like to emphasize, and I think is the key point of my talk today, is that you can't know if the lung cancer belongs to one of these molecular defined subgroups unless molecular testing is performed. So what happens when these mutations occur? And Dr. Roto just gave a phenomenal talk about EGFR, and I'll also use EGFR as my example here because it is probably one of our most common mutations. So EGFR belongs to this family of ERB receptors. They can be found in normal cells. And what it stands for is epidermal growth factor receptor. And so what happens is when a signal comes from outside the cell, it binds to the EGFR, which is that green little tuning fork here. And this activates this downstream pathway, meaning that it tells the cells internally to send signals for cell growth, cell division, things that it should be regulating. We know that it's found in the skin, in the GI tract, and different lining of the body, in your nails. And this is why, as Dr. Oto mentioned in her talk, when you have these EGFR therapies, it can have these side effects in the skin, in the GI tract, in the nails, etc. But when these mutations occur that we're really interested in, what happens is that now this cell growth signaling continues, irrespective of whether or not there's an actually external signal telling it to occur. So essentially what is happening is now your cells are growing independently of whether or not your body is telling it to grow. And that is actually a very key defining feature of cancer in general, is essentially the cells are growing without your body's ability to control their growth. Targeted therapies are a key type of treatment now, especially for non-small cell lung cancer. These mutations occur much more frequently in adenocarcinomas and or in patients with light or never smoking history, but that is not absolute. And this is why, for me, I think molecular testing is incredibly important for patients, all patients with non-small cell lung cancer. What I have listed here is for patients with stage 4 metastatic non-small cell lung cancer. Here are some of the different targeted therapies for a specific molecular alteration. You see there's an incredible list. So in that second row in that light blue, these are the current approved frontline molecular alterations, meaning if your cancer, your loved one's cancer has one of these molecular alteration, we believe that any number of the therapies in the green box below is superior to chemotherapy and or immunotherapy in terms of your frontline treatment. This has been, shown in innumerable clinical trials. On the far right column, you'll see the orange molecular alterations. Now, these are molecular alterations for which we think in the front line, it is still possible, it is still better to receive chemo and or immunotherapy if appropriate. But in the second line, instead of doing chemotherapy, you can get one of these targeted therapies. Now, just as an example of how quickly we are moving in this space, I submitted this talk, about 2 weeks ago, and already this is now outdated because as of last week, there's been yet another approved targeted therapy in the second line for something called an NRG fusion. And the drug, and I'm probably butchering the name, is called zenocutuzumab, and it's approved for patients who progressed on frontline chemoimmunotherapy. However, targeted therapies really are not just for stage 4 anymore, and this is going to be the focus of my talk today, is that molecular testing, understanding what are the DNA changes in the cancer, it's not only just important for patients with metastatic cancer, but also for patients with earlier stage cancer. The focus today will be on EGFR and ALK, for which we have the predominant results from clinical trials, but there is more work that is being done in other molecular subtypes. So if we think about first for patients who have what we consider surgically resectable non-small cell lung cancer, meaning a thoracic surgeon feels with confidence that they can remove all the cancer, what is a typical process is on the left, the surgeon not only removes the primary lung tumor, but also should do an extensive evaluation of the lymph nodes, the neighboring lymph nodes, to see if there's any evidence that the cancer spread to these lymph nodes. What then happens is that specimen is taken to the pathologist, and they will look under the microscope to help us identify the specific subtype of non-small cell lung cancer, tell us if the margin looked good, meaning that all the cancer was removed, and more importantly, do we see any evidence of lung cancer in any of these lymph nodes that were removed? Depending on those findings there, and now, of course, I'll explain why molecular testing is incredibly important in this arena. There are really currently 3 major options. We can consider observation, meaning sometimes patients with incredibly small lung cancers, you don't need anything more other than continue close follow-up with scans. You may be offered chemotherapy. You may be offered immunotherapy after the fact. And today we'll talk about why you should maybe be offered targeted therapy as well. So the first study I want to highlight is the ADORA study. So this is patients who had an EGFR non-small cell lung cancer. And this is very important to note that this is specifically for the sensitizing or common EGFR mutations that Dr. Roto showed in her lovely graph of the different types of EGFR mutations. And these are patients who had stage 1 to 3A non-small cell lung cancer who underwent a complete surgical resection. Brain imaging was also done to make sure that there was no evidence of cancer that spread to the brain, which is incredibly important in lung cancer. And then patients could either have received chemotherapy if their oncologist felt it was appropriate, or go straight onto this study. Patients were then randomized in a 1-to-1 fashion to receive either the osimertinib, Dr. Roto talked about is Tagrisso, which is used in the front line in stage 4, or they can be randomized to receive placebo. And these patients received treatment for up to 3 years, and they were continuously followed with scans. What the study showed is that these are the overall survival curves, is that at 5 years, there was statistically significantly improved 5-year survival with osimertinib of 85% compared to 73% with placebo. This is in the stage 2 and stage 3 patients. But even if you add those stage 1 patients, so these earlier stage patients, you see that there remains a survival benefit for the addition of osimertinib versus placebo. And this was approved by the FDA in December of 2020 for patients with surgically resected sensitizing EGFR non-small cell lung cancer. In a very similar study, here we have something called the ALINA study. So they took a very similar population of patients, the stage 1 to 3A. And these were patients who then had ALK positive non-small cell lung cancer, another, probably our second or third most commonly found mutation. In this situation, though, patients were randomized to either receive the alectinib, which is a second generation ALK targeted therapy for 2 years, or they were randomized to receive chemotherapy for every 3 weeks for 4 cycles, as is considered standard. And these patients were also followed for recurrence. And here we see the progression-free survival because we do not have the overall survival as of yet. But you see that as compared to chemotherapy, alectinib did lead to a significantly higher duration of time in which the cancer has not recurred. You'll see that that is 44 months with chemo and not yet reached with alectinib. And so even though we haven't seen the overall survival results, I think this data is certainly very, very promising. And in fact, alectinib was approved by the FDA in April of 2024 for surgically resected ALK positive non-small cell lung cancer. We'll shift gears a little bit to unresectable non-small cell lung cancer. Now, sometimes patients present with a diagnosis of non-small cell lung cancer, and for any number of reasons, it is felt to be not able to be surgically resected, and that could be, lung function status, the extent of the disease, personal preferences, logistics, any number of reasons. But in this situation, patients can still be offered curative therapy with what we call definitive chemoradiation, or chemo-RT is what you'll hear us refer it most commonly as. So the Pacific study, and I apologize for the typo there, really had set the standard for us for how to treat these patients with unresectable stage 3 non-small cell lung cancer, because in this study, they took patients who had stage 3 non-small cell lung cancer, received definitive chemotherapy and radiation, most frequently given together. And if they had no evidence of cancer progression at the end of this, patients were then randomized in a 1-to-1 fashion to receive durvalumab, which is a type of immunotherapy, or a placebo for up to a year. And patients must have had their first dose of durvalumab within 42 days of completing the chemo and the radiation. And then patients were followed closely, like all studies, with scans continuously. And cut to the chase, this has been approved since 2018, but we are happy to see that even as the data matures, at 5 years, there is a continued improvement in overall survival with durvalumab of 42.9% compared to 33.4% with placebo. So this has been the standard of care for some time now for these stage 3 patients. But the important question has been asked, does this apply to all non-small cell lung cancer, or in this instance, should we also be looking at molecular subtypes? Now, I will say that when the Pacific study was first initiated, we didn't know that as much about EGFR and ALK and all these other subtypes. And so these patients were not specifically excluded from the Pacific study. And so what this Dr. Naidu and her team did is they went back and they looked at patients who were on Pacific who had an EGFR non-small cell lung cancer, and they wanted to see in this subgroup, did patients benefit from durvalumab? You can look at the progression-free survival curve on the left, the overall survival curve on the right, and you'll see that it's pretty clear from these two graphs that is, overlapping, that there not seem to be a benefit of the durvalumab in blue versus the placebo in yellow. And so if you're thinking about therapies, if there really is no benefit in controlling the cancer or living longer, there probably is no benefit of this drug at all, because the negative side, of course, is that there's going to be toxicities that you'll be incurring. And so here comes the LAURA study, which is patients now with this locally advanced unresectable stage 3 EGFR non-small cell lung cancer, again with sensitizing EGFR mutations. They must have received definitive chemoradiation. This could have been done concurrently, so given together, which is the most frequent way that we do it, or sometimes sequentially with chemo first followed by radiation. Much like the Pacific study, they had to have no progression of disease after definitive chemo and radiation, and they must have started the study within 6 weeks of finishing the chemo radiation. In this study, patients were randomized now in a 2-to-1 fashion to receive osimertinib 80 milligrams once a day indefinitely, or placebo, or nothing, surveillance. And patients, again, were continuously assessed. Importantly, they were also assessed with CT scans and MRI brains because, again, brain metastasis is a frequent occurrence in non-small cell lung cancer. And even in an earlier stage, it is incredibly important to keep on looking at the brain and monitoring it. So here we saw the results of the progression-free survival. This was presented by Dr. Ramalingam this year at our ASCO meeting. And it is very clear to see that osimertinib led to an impressively improved progression-free survival as compared to placebo. You see the median progression-free survival with osimertinib was just shy about 40 months, with placebo is just about 6 months. Again, we don't have the overall survival data yet. That is still maturing. But I think, this level of benefit was strong enough for the FDA to also approve osimertinib for patients with unresectable non-small cell lung cancer with EGFR sensitizing mutation after definitive chemotherapy and radiation. So what are some benefits of targeted therapy and why it's really important to know if the cancer belongs to one of these groups? Well, first of all, this is specific to the cancer subgroup. So now we're not treating, one cancer just like the other. We know now that there are different types of non-small cell lung cancer, so we want to offer the best therapy for the right subgroup. Often these targeted therapies can be in oral pills. That is not true for all, but case for many of them, and that does improve quality of life. You do not have to go to the infusion center every couple of weeks, wait for parking, things like that. It is simply pills that you take once or twice a day. And as Dr. Rota also talked about in her talk about EGFR, but this is also the case with many of the other molecular subgroups, many of these targeted therapies have excellent brain penetrance. So not only can they treat brain metastases if they exist, but more importantly, prevent brain metastases from occurring, which is quite important. So my big takeaway points today. So non-small cell lung cancer is divided into many molecular subgroups. We have now effective targeted therapies that are available against these mutations. They lead to an improved overall survival. They're often better tolerated. But thankfully, these targeted therapies are not just for stage 4 lung cancer anymore. We're seeing more and more that there's a benefit to using these targeted therapies in earlier stage lung cancer, whether patients have undergone surgical resection or definitive chemoradiation. But again, I think my major takeaway point today is that we need to consider next generation sequencing for all of our patients with non-small cell lung cancer because we cannot know about the role of about targeted therapy unless we know about the subgroup of lung cancer. That'll help us come up with the optimal treating plan. And so with that, I want to thank you for your attention.
Thanks, Dr. Chin. Excellent talk. So hopefully, as you give this talk in the future, there'll be more and more subsets that you're adding as far as the targeted therapies. And so I'm going to invite Dr. Roto back as well, and then we'll get some questions for both of you related to both of your talks. And so again, a fabulous session on targeted therapies, both EGFR across basically the spectrum, but we also heard about ALK in the earlier stage setting. And so a couple of things to clarify in your talks. One question, Julia, that came up in your talk was talking about plasma and how plasma was a biomarker in the setting of kind of combination therapies. And I know that in these types of forums, we've talked about plasma for a different use before, looking at mechanisms of resistance, et cetera. And just for the context for the audience, can you kind of describe how plasma might be used in EGFR mutant lung cancer and whether or not looking at plasma before treatment is ready for prime time?
Yeah, it's a great question. So when I think about plasma testing, we're talking about, when you have your blood drawn and they sequence any tumor DNA that's been shed into the blood, looking to see if they can detect tumor DNA associated mutations. And the ones we're often most interested in are all the various actionable mutations we saw in that pie chart of EGFR, ALK, and others. And sometimes if the tumor is shedding enough DNA into the blood, we can pick them up and identify them. The most classic way that we use this is for initial identification of a mutation. If you're newly diagnosed as part of comprehensive testing, we'll know, do you have a mutation or not in the tumor cells? And while the most sensitive way to do that is on a tumor biopsy, we're actually feeding the tumor cells themselves into the test. The tumor DNA is sort of a backup way to do it in some sense that is certainly less invasive and sometimes comes back faster, but it's less sensitive. The tumor might just not be shedding enough DNA. So it's like it's good to rule in a mutation, but you can't use it to rule out a mutation if it's negative. And that's really how we're using that as part of our standard of care in lung cancer these days. There's a lot of research going on looking at other ways to try to use plasma-based testing to guide treatment decision-making, whether that's trying to understand, can we use plasma to monitor treatment response or monitor risk of relapse, people with earlier stage disease, maybe after surgery or radiation. Those I would consider all to be research questions right now and really exciting areas of research, but not yet part of our standard of care in some sense, because we're not quite sure what to do with that information. If it turns positive or negative, we don't yet know if you modify what you're doing based on that information, are we actually having an impact on how people do long-term? Or are we just making ourselves feel better because we're changing things, but we haven't changed the long-term outcome? So that research is so important and I think really exciting, but ongoing. Now, the example that I mentioned is maybe a third way to use this, which is trying to risk assess disease and try to figure out, is this higher risk disease where more intensive therapy might be necessary? And again, that's not quite standard of care just now. You're not going to see in the national guidelines, plasma positive EGFR lung cancer, do this. And the clinical trials that I mentioned weren't designed to kind of ask and answer that question. So it's what's called a subgroup analysis, where they look back and you kind of slice and dice the data a little bit and say, does anything we could see in there seem to predict for more or less benefit? And then can we try to use that in real life as one factor among many to guide our conversations about this? So for me, I like using that as one piece of many. And I do like knowing my patient's plasma status for EGFR at diagnosis, if possible, because I know that people who are plasma positive, in general, it correlates with a higher burden of disease. And it also tends to correlate with kind of more likely to have brain metastases. Not that that's a causative thing, but just that it goes along with cancer that's a little more extensive at diagnosis is also a little more likely to have brain metastasis. Now, your plasma status is not essential. I think your oncologist can also look at your scans. I think we can all recognize when it looks like a scan, unfortunately showing a little more extensive disease than we wish, or where our patients are sicker at diagnosis than we wish they were. Maybe their cancer's a little more in more places at initial identification. So it's not required, but I find it helpful just when I'm trying to quantify, one factor again among many in risk assessment.
And I promise I'll get to you, Dr. Chin, but really quickly, you said two things and really kind of quick answers to these ones. One, is there a role, this is for you, Julia, is there a role for radiation for brain metastasis? And then the second, when you look at an NGS report for someone with a classical EGFR mutations, are there any additional mutations you're looking at to try to guide your decision making in terms of whether to stick with osimertinib by itself or whether to add something?
Yeah, I'll do those quickly. So first, brain metastases. So certainly brain radiation is a useful tool for treating brain metastases, and it can be well tolerated. It's very focused and precise to just a few spots. But one advantage, as Dr. Chin also brought up, is that our modern targeted therapies often are very brain active, and that they get across the blood-brain barrier and they treat brain spots with a lot of confidence, almost as much confidence as we have for treating disease in the rest of the body. And in those situations, like when I'm starting on EGFR lung cancer or ALK for that matter, I'll usually put off radiation because it does still have risk of side effects and some risk of long-term side effects, and try to let the pills or pill-based combinations work on their own first. But then we want to watch those brain spots very closely so we're ready to treat them if they do grow. So that's the first answer. And then the second one, remind me, it was about
Yeah, the folly of asking too many questions at once. Yeah, so I said that we've talked about biomarker testing and its importance, and we sometimes focus on the key biomarkers like
Co-mutations, yeah,
EGFR. Exactly. Are there co-mutations that impact what you do?
For me, I'm actually not looking at co-mutations, but I will say that there are some like TP53 co-mutations or TP53 and RB co-mutations that have been associated with shorter on average duration of benefit to targeted therapy pills like osimertinib alone. And maybe associated with increased risk of certain forms of acquired resistance, like transformation, something called small cell lung cancer, which is a more aggressive, a little harder to treat form of lung cancer, though lots of progress, as you heard in an earlier talk. People on those with those features do have a little shorter average duration of benefit, and they do gain benefit from adding combination upfront therapies. To my eye, I think the degree of benefit is similar in terms of magnitude of gain whether you do or don't have those mutations. I'm personally not intensifying based on that particular factor, but there are folks who do like to intensify based on it. So I certainly see that happening in practice, and I think it's within the realm of sort of a reasonable way to interpret the data. And certainly if I had someone who was on the fence and they had other features that made them kind of high risk and they had that co-occurring mutation, just one more thing that's going to tip those scales towards maybe we should do upfront combination versus if you don't have that co-mutation and you have exon 19 deletions, which tend to respond longer to therapy, and you don't have brain mets, and everything then starts tipping the other way. So it's like a scale deciding amongst these factors.
Excellent. So we spent a lot of time talking about intensification, but for you, Dr. Chen, de-intensification in the adjuvant setting. So basically in ADAURA, there was an option of whether or not to give chemotherapy. ADAURA, as a reminder, is the adjuvant osimertinib trial. And in ALINA, they bypassed chemotherapy altogether. So how do you, and ALINA, of course, is the correlate ALK study. So how do you think about chemotherapy, and how do you have those discussions with your patients around chemotherapy in that setting?
Yeah, I think that's a really great question. So, I mean, at least in the ADAURA study, it wasn't really designed to answer whether or not you still need chemo, right? It was kind of a physician's choice after discussion with the patients whether or not adjuvant chemotherapy was given. I think that we of course want to move beyond chemotherapy as much as possible, but we do have to remember that the reason adjuvant chemotherapy has been a standard of care for so long is that there are studies and meta-analyses that show that there's a benefit in overall survival with the use of adjuvant chemotherapy, particularly if it was a higher stage, particularly if these are lymph node positive disease. And, we don't know yet if the adjuvant targeted therapy alone is going to be enough to also be an additional benefit on top of the chemo, right? Is the benefit additive, or is targeted therapy powerful enough that you can omit the chemo? We don't know that. And so for me, when I see a patient with surgically resected EGFR or ALK non-small cell lung cancer, if they do have a higher stage, if they do have lymph node metastases, and they're physically fit, I do actually talk to them about adjuvant chemotherapy. I do think, in my opinion, there is still a benefit. And then, of course, doing the TKI afterwards. Now, if a patient is not fit to get adjuvant chemo, really has a strong distaste for it, understandable. But now we know that we then have the TKI to come after.
Yeah, I think that mirrors my practice as well. So we will get to the Q&A session, but I want to ask one last question to Dr. Chen. So it's almost like a Goldilocks type of thing, right? Where you do forever for your adjuvant TKI or your adjuvant, I guess I would say, or consolidation TKI, or you do 2 years or you do 3 years. I have some patients who struggle with the concept of stopping it if it's working. So how do you think as a field we can sort out that type of question, and what is your practice surrounding the duration of TKI?
Yeah, I think that's an incredibly challenging scenario. In ALINA, it was 2 years. In ADAURA, it was 3 years. But then in LAURA, which is for stage 3, it was indefinite. I think this is where that perhaps some of these high-risk features that Dr. Hotel talked about in her talk may come into play, right? So if in this setting of EGFR, and I'm sure we'll see more with ALK as well, if your cancer has one of these more high-risk features, might you benefit from a longer consolidation period or adjuvant period? This is also the role of perhaps doing that plasma testing, as she was just talking about as well, because, you know, there's a lot of studies that is retrospectively seeing that if you don't have ctDNA that's detected, or if you have clearance ctDNA, that's a really positive prognostic factor. And so perhaps if you do have that ctDNA clearance, we can get away with a shorter time of consolidation. And this is actually conversations we're having with our patients as they're approaching their 2-3 year mark is, well, you know, what do we know so far? What do we know about the risk features of your cancer? And then how are you tolerating the therapy, right? If they're struggling to get to that 2 or 3 years, and I say, you know what, we've done our best, we've done what this trial recommends, I think we should stop. But if they're doing incredibly well and they have some of these other features, or if we can detect ctDNA positivity still, that might be the patient we talk about extending their period of adjuvant or consolidation.
Yeah, I think very, very kind of great answers to questions that are unresolved in the field. But it's good to have the opportunity to ask these questions now with the kind of evolving therapeutic landscape. And so now we will turn to the question and answer segment. And so I want to invite Dr. Shields and Dr. Cooper back. And so thank you so much. We have lots of questions here. So thank you so much to the audience for submitting them. And we'll do our best to get to all of them, but we'll alternate so we get input from everyone. And so I will pose the question to the person who gave the talk, but others can feel free to chime in on the question as well. Understandably, the first that are trickling in pertain to ADCs. So on the spot, Dr. Cooper, can you explain why there is anemia related to some of these ADCs? And then do you think overall that there's less side effects or fewer side effects with ADCs compared to our traditional therapies?
Yeah, thanks for those questions. I probably should have included more of this in the talk. So ADCs, although, you know, a new class of drug, as you saw in the talk, they're really kind of just like a dressed up chemotherapy. So they are still very similar to chemotherapy in terms of side effects. And one of those can be low blood counts, including anemia or hemoglobin, but also white blood cells and platelets too. It's a pretty common side effect actually across ADCs because, as I had mentioned, those warhead or sort of payload molecules are very potent chemotherapies, strong chemotherapies. And so they do still have that chemotherapy effect on damaging cells that divide quickly, like those in the bone marrow that create the blood cells. I think it's important that I emphasize that ADCs do not have fewer side effects actually than other drugs and may actually even have more or potentially at least different side effects than the therapies that we're currently using. For example, datopotamab deruxtecan and trastuzumab deruxtecan, a lot of those ones with the deruxtecan at the end of it, ifinatamab deruxtecan, patritumab deruxtecan, they all have that suffix. Those drugs can affect the eyes. They can have some eye toxicity. They can have some what we call stomatitis, which is sort of like mouth sores or sort of irritation of the mucous membranes of the mouth. Can also have some lung toxicity like interstitial lung disease, which is sort of like inflammation of the lungs that can cause trouble breathing. All of those side effects are very important to watch out for. And while not super common, can be serious. And so just to emphasize that although the side effects are different than other drugs that we use, they're certainly not less, unfortunately.
I agree. I think that's a critical point to make. This question, I guess, for Dr. Roto, just to explain what we mean when we say CNS mets, the question asked specifically is that, does that include cancer that enters the spinal fluid when we're thinking about the activity of these EGFR targeted therapies?
Yeah, that's a good question. When I talk about CNS meds, I'm talking about, you know, central nervous system spread of the cancer, metastatic disease. And that really comes in two key forms. You know, we think about more classic CNS metastases, which you might see, again, I'm going to give you sort of the jargon so you've heard it, is like things like parenchymal metastases, if you hear those words. That basically means tumors that are growing in like a discrete spot in the brain. When you do a brain MRI, you can see like a dot there or a spot there where it's been growing. The other form of spread to the central nervous system is what's called leptomeningeal disease. And that's disease that affects the fluid around the brain and spinal cord, the cerebrospinal fluid or CSF, and we're the lining of those areas. And I think we traditionally think of this leptomeningeal disease as being a more challenging form of disease to treatment. So when I think about a drug, what's the easiest spot for it to treat? It's the rest of the body, where it doesn't have to get across the blood-brain barrier. And then if it gets across the blood-brain barrier, kind of the next spot, kind of threshold, is treating kind of more regular CNS metastases like that develop as single spots. Those are probably a little easier to treat. They're more likely to be allowed on clinical trials because you can measure them and see if they're responding or growing and feel confident. Are you really offering control? And you have a backup plan, right, where you can treat that spot with radiation in most cases if it's not under control in therapy. And then the most difficult form to treat, unfortunately, is this leptomeningeal disease, where it's diffuse. It's hard to see on scans. Sometimes it's not even visible on scans. It's just detected by symptoms and then by sampling the CSF fluid looking for cancer cells in it. And that's the hardest spot to get a drug into at enough level to kind of really impact disease control. And a lot of clinical trials won't allow this because it's hard to get a sense of, is the drug controlling it? Are we getting benefit from giving the drug or not? And it's harder to treat. Usually not as often going to use things like radiation to treat it because it's diffuse. You can't target it to one spot. Or it can reseed. If you treat one spot, what's in the fluid, it can reseed there again without kind of lasting benefit. Now, a lot of our drugs that are active against CNS disease, the very highly active ones, often we've also seen activity against leptomeningeal disease. So when I talked about things like osimertinib, the EGFR inhibitor, or we talked about alectinib, an ALK inhibitor, these are highly CNS active drugs, where we also, I think, with reasonable confidence, hope for activity against this leptomeningeal disease. But it is a different set of criteria in that I think when I'm looking at treating a patient, it's really the most active drugs where I usually expect to see activity against that leptomeningeal disease. And it's, clinically, it's a very tough scenario where I think there's a lot of need for new drugs to offer even greater numbers of active therapies for that class of disease.
I agree. And I think also a space where we need more trial data that not exclusively, but at least intentionally enrolls patients with that phenotype of disease. So the next question is for Dr. Shields, and I think it piggybacks off some of our discussion. And the question is, after our discussion of tarlatamab and the potential side effects, the necessity of hospitalization for the initial infusions, the question is it safe enough for patients to get it from their regular doctor, or do they need to go to a specialty center to get it?
That's a wonderful question. I think that, as this drug has rolled out since its approval in May of this year, there has been, a lot of hesitation from oncologists because they may not have the experience and they will express some hesitancy because, it is a new class of drugs and we really should have all of our ducks in a row to support patients before we get started. And so hospital systems, oncologists, clinics really are pumping the brakes to make sure that we have everything in place so we can safely offer this. And so, I would say that, finding a larger or an academic center that has experience with these type of BiTE therapies, these, molecular glues, these super glues we mentioned, I think is a great first step. And then, either going to that location or seeing if they can help with your local oncologist or center to help either consult, inform, or collaborate with them to provide care. Here at Indiana University, we are providing tarlatamab at our hospital, our university hospital in Indianapolis, and all of our satellites really are referring into us for the first few cycles, so we can make sure that everything is safely administered in a very controlled fashion. Everybody is trained, there's in-service, and so we want to make sure that we provide this care safely in a uniform fashion to all patients. And so your system, your hospital system, your cancer clinic may look a little bit different. Good questions to ask your doctor, get a second opinion. That's always a great next step, and see if there's an expert locally that can help, that has experience with these drugs to help inform your care to provide it safely.
I agree. And I think these are not questions unique to tarlatamab. I think when we encountered amivantamab in clinic as well, with that infusion reaction that many patients have when it's given intravenously, I had a lot of my colleagues in the community setting where there was some difficulty or a lack of resources recognizing that toxicity. And so our patients were sent to the emergency room in other areas. And so as a group, we did see some of those patients at the kind of the central academic site initially until they gained the sufficient expertise. And so I hope that it's going to be a similar model where perhaps you start in a central model and then you can disseminate it out, because ideally you get care closer to home. And so the next question is for Dr. Chin. Just to clarify a term that I think everyone used throughout their talks, right? What does an actionable alteration mean? What is actionable?
That is a great question. So actionable alteration, as we commonly use it, means that there is a mutation. So a molecular alteration in the DNA of the cancer cells, and it results in a molecular change. So the EGFR, ALK, and a number of others that was on that slide in my presentation. More importantly, for which we actually have a therapy that is targeted specifically for that alteration. So it's actionable because we have effective therapies for it. Now, what we know now is that too, we have many, many alterations that are detected for which one, we don't really know if it's meaningful, is it actually playing a role in the cancer's growth and spread? And two, if they are meaningful, we may not yet have an effective therapy against it. So, those are obviously things that we're continuing to research on, but for right now, actionable means that it is meaningful to the cancer itself, and more importantly, we have therapy for it.
Exactly. And as you mentioned, the definition of actionable is ever evolving. And so that's a great thing. And so the next question I probably will pose to both Drs. Cooper and Dr. Roto. We have a lot of EGFR questions, but some of these are nuanced and pertaining to the type of therapy. And so the first one, I guess, for Dr. Cooper and Dr. Roto can chime in as well, if inclined, is how efficacious immunotherapies, TILs, CAR-Ts, personalized vaccines, et cetera, are for EGFR mutant lung cancer and in solid tumors altogether, I guess. And is there work being done in that, not in solid tumors, but lung cancer, wild-type lung cancer altogether? And is there work being done in that front?
Yeah, I can start. And definitely, please, Dr. Roto, jump in because this is definitely your area. The traditional teaching is that immunotherapy is not that efficacious in patients with EGFR mutant lung cancer. And the reason for that is that the EGFR mutation itself seems to sort of impart this very immune suppressive environment where even if the PD-L1 expression, which is the marker on the tumor that tells us how likely is it for the cancer to respond to immunotherapy agents, even if that number is high, we just don't think that there's a lot of effectiveness for giving those agents in the setting of EGFR mutations. So that marker doesn't really mean much in the setting of an EGFR mutation. And indeed, we've found that actually, when you give those agents after an EGFR targeted therapy, that's actually a very unsafe combination, and patients can have a lot of dangerous toxicity. For example, lung inflammation, like pneumonitis is the word that we use. It's a very significant risk factor. So for that reason, we tend to steer clear of using immunotherapy in EGFR mutant lung cancer. Although, I do know sort of one-off or sort of anecdotal cases. I think probably everyone has heard of a handful of cases of patients who maybe way in the later lines of therapy. They've seen a lot of therapy and their doctor has tried immunotherapy and maybe they have had some benefit. But again, it's not on a population level, the traditional teaching. I can throw it to Dr. Roto for more.
Yeah, I absolutely agree. It's I think it's hard for us as a field as well, because of course, immunotherapy has been transformative for a lot of our patients with lung cancer. We see sometimes very long-lasting, durable responses. I think it's very hard for a lot of our young patients with these actionable drivers. They're in a situation where immunotherapy on average is not going to be very effective for them. And I agree that I mostly avoid current available kind of we call checkpoint inhibitor immunotherapies like pembrolizumab or other medicines like that. Until very late line, if I use it at all for my patients with an EGFR mutation. This is a very different cancer, right? We think about kind of classical lung cancer, we think it might be risk of history of tobacco use. This has had a lot of carcinogen exposure. It's a very kind of genetically messy cancer, a lot of mutations, inflammatory environment. The immune system has kind of a fighting chance to respond. But EGFR lung cancer, it's, there's one mutation or just a few mutations, it's a very different tumor and therefore a very different interaction with the immune system. Now, the question asked about other emerging immunotherapy options. So, of course, if current checkpoint inhibitors that we use for a lot of lung cancer aren't working, will emerging novel technologies change this? I think that's currently unknown. It's a bit of a black box. Can we activate the immune system in other ways to produce responses to these, I often call them immunologically cold tumors? And that's think the holy grail in oncology can make cold tumors hot or reactive to the immune system. EGFR is a great example of that. I would say right now, this is really early days. I think clinical trials are far, few and far between right now. And if they're around, they're in very, very early phases of development. We don't yet know clinically what the chances are of activity. So it's a bit like, rolling the dice or, hitting a Hail Mary pass where we don't yet know if these agents will work. But I do think they warrant further study. I think we're all hopeful that one day as immunotherapy technology emerges, our understanding of the immune system emerges, hopefully we'll be able to target these more difficult cancers as well.
And I think very well said by both of you. I also enjoy the sports analogy, Dr. Roto. I did not know you were a sports fan. We'll explore that later. But for so this question I actually posed to Dr. Chen because I think it's an insightful one, and you talked about local therapies. So there's a question in the audience about how they want to know about options for surgery for stage 4 patients and how we think about whether to incorporate surgery for stage 4.
Yeah, I think that is a really great question and something we are exploring more. I think traditionally, right, we don't think about surgery for stage 4 because we think about surgery as a curative option, and often that's not what we're thinking about in stage 4. I think about surgery in kind of two settings in the stage 4. So one, if someone has a patient has a metastasis that's going to be a life-threatening in an area, and the most commonly one could think about is perhaps metastasis to the brain or metastasis to the spine, where there is impending bad things are going to happen, brain swelling or affecting the spinal cord, potentially affecting the way that a patient can move, then surgery would be indicated because that is going to be the quickest route to resolve some of these medical emergencies. Now, surgery, as a discussion, has been thought about more now as consolidation therapy, right? So we have patients who, especially in patients with the EGFR or ALK and some of these other actionable mutations, where the TKI or targeted therapy has worked incredibly well, and all their other sites of metastases appear to be quite controlled, except for maybe that one that's just out there and is more stubborn. In that case, does surgery play a role as consolidation, or in this instance to radiation? So do we surgically remove that site? Do we radiate it? Does having that clean scan, mean better outcomes in the long run in terms of disease control? But more importantly, are patients going to live longer with that? I don't know that we know the definitive answers to that, but certainly it is an option. I think it's very individualized. It depends on the site of disease, how big it is, how surgically feasible it is to remove it. What are going to be the morbidity of doing a surgery there? You're going to have to hold your TKI therapy. Do we feel confident that holding your therapy for that duration of time is safe? It's a very individualized discussion, but certainly for select patients, surgery could be indicated even in stage 4.
I agree. I think very, very personalized and individualized, and it is often a rarity to do. And so I want people to understand if your doctors are saying it isn't something advised, it's not because they don't want to cure you. It's just that it carries a lot of risk, and it's probably more harmful than any type of benefit in that scenario. And so this question is for Dr. Shields. The audience is asking, what would be your go-to regimen for limited stage small cell lung cancer, and what is your surveillance practice?
So, great question. I think that this is an evolving field. And so, particularly focusing here, I would say, on patients who have stage 2 or stage 3 small cell for limited stage. So meaning it's involving the lymph nodes, and surgery was not an option. So for my practice, typically is meeting patients. I do, typically refer my patients early to palliative care. I think having the most support, having dietitians, having early palliative care, really jumping on board with these patients and supporting them early, because this is an intense regimen and we want to make sure that they have every area of support that they need. And so typically that is meeting with the patient, discussing platinum-based chemotherapy. Typically, my preference is usually carboplatin. But that is a patient and physician discussion to discuss whether that's cisplatin or carboplatin. Cisplatin does come with additional toxicities and more chair time with infusions for fluids and such. And so meeting with the patient, discussing those side effects, and then having a patient referred to a radiation oncologist to receive radiation. Now, the schedule for radiation could be once daily or twice daily. If it's twice daily, it's typically very consolidated, and then most patients may have a very hard time getting radiation in the morning and also at night for such a intense schedule of over usually 3 weeks. Typically, I give 4 rounds of chemotherapy along with the typical radiation, which is given typically over 2 cycles. So you have an overlap of the chemotherapy in one area and the radiation given concurrently. We know that patients who receive at the same time and have the most overlap of those do the best. And if we are moving those areas to a sequential, that can impact negatively patients' outcomes. And so as we are getting through each round, I see patients with each round of chemotherapy to check in, see how they're doing. We do see that blood counts do drop with this regimen. And so really checking in, seeing how they're managing, if there's anything else we can support them. And as we're getting closer to the end of the regimen, we typically start discussing prophylactic cranial radiation or PCI, which is whole brain radiation for prophylactic or prevention of possible brain mets. I think having them meet with a radiation oncologist, getting as much information. We talk about the Maverick study, which is a SWOG study that'll read out in 2027, looking at the role of whole brain radiation or PCI versus active observation with MRIs every 3 months. So we talk about the caveats, and usually it's a patient and provider discussion. We weigh the risk and benefits. I have them meet with a radiation oncologist and to decide whether they'll pursue that or not. And then we do scans every 3 months, at least for the first 2 years. And then we start to extend out based on our NCCN or national guidelines for cancer management, because the risk of small cell coming back is the most in the first 2 years from diagnosis. So we want to very closely follow the patient and make sure that there's any changes, we catch it early and intervene early. So hopefully that helps.
I saw a lot of head nodding, so I think there's a lot of consistency across practices. And so this question is for Dr. Roto. And so the question is, if someone has started osimertinib by itself or Tagrisso by itself, and then they added the chemotherapy 6 months in, do we believe that the benefits extend to that population as similar to someone who starts with a combination up front?
Yeah,
I suspect there's nuance here, but
yes, definitely. And I think this is an interesting question because I get it from patients and caregivers, but also from other physicians. I think this comes up a lot. Can you say, start with the pills alone and then see if you like the response you get and then add chemo if you feel like you're not getting as much response as you wish you could have? And I have to say that's not a strategy that I recommend. And the reason is when you look at where the benefit comes in, these upfront combination therapies, it's a little bit less about that initial response and more about the durability of that response. So I think when we start osimertinib alone, a lot of our patients have a really nice decrease of disease, but that doesn't always correlate with the durability of response. And we carry both about how many people respond, but how long does that response last? So we don't know if we wait and let the cells kind of get into that kind of persister state and then add chemo, are we getting the same benefit as when we add it right from the beginning, or if we do one of the other combinations like amivantamab lazertinib right from the beginning? So my advice is really to, if someone's just been on for a few weeks and we're seeing them for a second opinion, having a conversation, that's a very different story. Or if someone was really quite sick from symptoms of their disease and they do a few weeks of pills and they're feeling a lot better and now suddenly a good candidate for things like chemotherapy, and it's a whole different story as well. But I'm usually trying to embark from the beginning or close to the beginning as possible with either upfront monotherapy or combination. So I suspect there is practice variation here, to be fair, but that's my own personal strategy and how I counsel people about it.
And there's trials in this space as well, trying to use ctDNA dynamics, et cetera, to inform when to add it. So Dr. Shields, a point of clarification on your last response to the therapeutic, I guess the regimens that you recommend for limit stage.
Obviously I must need more coffee. So just one more additional thing, I was focused more on PCI and scans, but standard of care is durvalumab monthly for 2 years to 2 years after. So that is an absolute must to discuss with your doctor. And I don't want to omit that. And so I wanted to update and my recommendations about after you have your scans for your 4 cycles, you've completed your chemo rads, and everything looks great. Getting immunotherapy with durvalumab monthly is a absolute standard of care. So just to clarify.
Fair enough. I think a very, very important clarification. So this is a question that actually harkens back to what we were talking about with respect to parenchymal versus leptomeningeal metastasis. Someone in the audience has astutely observed that they're seeing more patients being diagnosed with progression from lung cancer and manifesting as leptomeningeal disease. And why do we think that is? And do we have our treatment responses I guess, the way leptomeningeal disease responds to our current therapies, is it improved compared to historical therapies? And I will toss it out to anyone. I saw a lot of
jump in just quickly. I know we're running short on time. I do think we are seeing a little more of it, partly because our drugs are getting more effective, right? So we have good ways to control all the rest of the disease. I think the better we get at that, the more likely eventually to see that the meningeal disease to be the thing that comes out that causes us trouble, and because it's harder to treat, it's a little more resistant. So I do feel like we may see more of that, and it speaks to how critical clinical trials are and development of therapies are targeting this form of disease. So I think we're going to have to solve it if we want to get people longer term control in many situations. I do think even with that, our current therapies are getting better at treating it. So I think we're making progress, and we have ever more options to try to control it. We just run low on those options a little faster than we do for other forms of disease. And there's progress, but I agree it's difficult and a lot more progress is needed.
Yeah. And so in our last 3 minutes, I want each of you, with respect to your talk, to talk about just quickly say 2 promising things on the horizon in terms of clinical trials, investigational therapies, things that are here now that will be refined. And so I'll go around. So we'll start with Dr. Cooper.
Thanks, and thanks so much for the opportunity to participate in this great workshop. I think one thing I probably didn't emphasize enough is that trastuzumab deruxtecan is the only approved therapy right now as an ADC for lung cancer, and so other ADCs, which I've mentioned, are all sort of investigational and coming. But I think that the approvals are eagerly awaited, and so we're looking for the approvals both in non-small cell lung cancer and small cell lung cancer to be coming in the coming couple of years.
Dr. Chin?
Yeah, I think that something that I'm really excited to see more about is using these targeted therapies in the neoadjuvant space. So for patients who are surgically resectable, we now can consider, in the absence of one of these mutations, chemoimmunotherapy. But again, with such effective targeted therapies, is there a role for using them prior to surgery? I think we're seeing more and more studies come out. So I'm certainly looking forward to that. And I'm also looking forward to see, can we at least compile, from different institutions work together to look at some of these less common mutations. So we talk about EGFR and ALK, there's ROS1, RET, MET, and what is the role of the targeted therapies for those mutations in the early stage?
Excellent answer. So Dr. Roto is next on my camera,
Great.
on my screen.
So I'm going to talk about, I guess, emerging therapies, right? So what do I hope we're going to have available in the next year for EGFR that maybe isn't available today without a clinical trial? And the 2 things I'll highlight are, one, those EGFR exon 20 insertion active pills. Exon 20 insertions have always lagged behind the more common mutations because they're harder to treat. There are some drugs showing really nice responses in clinical trials, pretty far along in clinical trials. So I'm hoping these are going to be available for our patients who can't be on a trial. So that's 1. And 2, we've talked about antibody drug conjugates. There are several antibody drug conjugates which have shown really nice activity for EGFR lung cancer at resistance to things like osimertinib, which I think are going to add to our list of effective options for these patients. And again, I'll be shocked if they're not available in the next year outside of clinical trials. So both I'm very hopeful on for the future.
Exactly, and we don't want to shock Dr. Roto. So now we'll go to Dr. Shields for our final.
Yes, absolutely. So, thank you for the opportunity to speak today. An exciting revolution for small cell lung cancer. I think we have seen, obviously, the antibody drug conjugates with these Trojan horses, this molecular glue with tarlatamab, immunotherapy with training the immune system with durvalumab in limited stage. We're seeing that really the shift is now, how do we use these therapies earlier? And so that whether that is in the first line setting with novel combinations that are being actively studied with these new drugs, or even in limited stage. And so I think staying tuned to seeing how we can sequence and when is the right time for each of these approaches. I think that's one is what is the right sequence? How do these chips fall appropriately, and when do we use what and for what patients? I think the second thing that really speaks to it is that for small cell lung cancer, patients are living longer. They are being cured. They're winning the victory on this disease. And so it is our job as oncologists and your cancer team to help support you, to have you see palliative care early, to address cancer-related symptoms early, to work with a dietitian, and to have all of that support to stay on therapy. Considering a drug called trilaciclib or Cosela, which is a supportive care medicine, to help reduce the risk of those side effects of chemotherapy, like lowering of the blood counts or anemia or infections that might end you up in the hospital when you have to delay therapy, which is what you ultimately need. And so how can we support you? This is a marathon, not a sprint. And we want patients living longer, having happier lives, and really tolerating therapies for the long term, and hopefully to reach cures for every patient with small cell. So I think really exciting time. Thank you.
Yeah, and I echo everything you all said. I cannot say anything articulated any better. And I think I just want to thank the four of you for joining us. You truly are people who are helping patients live longer, and it's always a pleasure to learn from all of you. And so with that, I just want to thank our sponsors. And so thanking AstraZeneca, Takeda, Regeneron, and Daiichi Sankyo. And I also want to thank all of you guys for joining today's program, pushing through these kind of excellent questions and kind of whatever time zone you're on, joining us and always participating in this program. It is for you. We do what we do because of you. We're always inspired by our patients. And we hope to improve the programming. So there is a post-event questionnaire link at the bottom left, or look out for an email if you have any feedback for how we can improve the programming. So thank you so much for joining today.